is testing TDM1 in the adjuvant setting. One of them is the well-known and landmark Catherine study in adjuvant setting in HER2-positive breast cancer post-neoadjuvant treatment who still have residual cancer. And we have the ATTEMPT study, which was presented a year ago, using adjuvant TDM1 in low-risk HER2-positive breast cancer. So the Christine study, as you can see, it had been testing the TDM1 plus pertuzumab as investigation arm versus a standard treatment arm, which is TCHP, which is a well-known kind of chemotherapy protocol. Most of us, they are familiar with in the neoadjuvant setting of HER2-positive breast cancer. Patient had 6 cycles of either of these treatments, and after surgery, they will continue either dual anti-HER2 for those treated with chemotherapy in the neoadjuvant setting. For those who had received TDM1 plus pertuzumab, they will continue that to complete a year. Of course, adjuvant chemotherapy here was recommended for those who still have residual disease, whether in the primary tumor or in the lymph nodes. The primary endpoint of this study was PCR rate post the 6 cycles of the neoadjuvant treatment. Among those patients, like 444 patients who have been enrolled in this study, the median age was around 50, almost 40%. They had hormone receptor positive, hormone receptor negative disease, and 83% had baseline stage 2 to 3A, and the remaining 17%, they had like really advanced stage like 3B to 3C. Okay, so the primary endpoint was presented earlier, like a few years ago, and it showed that the study was negative, which means that the PCR rate for those received TDM1 plus pertuzumab was 44%, while for those who received chemotherapy, TCHP, it was like 56%. So chemotherapy plus pertuzumab, dual anti-HER2, was superior to TDM1 plus pertuzumab. So it's a negative study. The only thing positive about this study that the safety profile and toxicity profile of TDM1 plus pertuzumab was favorable in comparison to those who received the chemotherapy plus dual anti-HER2 in the adjuvant setting. What about the long-term outcome like event-free survival? As you can see, that the event-free survival was significantly worse for those who received TDM1 pertuzumab in the neoadjuvant setting in comparison to chemotherapy plus dual anti-HER2. While invasive disease-free survival was not statistically significant between the two, and probably this is because of the effect of the adjuvant chemotherapy that had been offered for those who received TDM1 pertuzumab in the adjuvant setting post-surgery, especially those who have residual disease. This is an interesting slide, as you can see that those who achieve PCR, regardless of the treatment arm they received in the neoadjuvant or adjuvant setting, they did much better in comparison to those who did not achieve PCR, regardless of their treatment backbone. So, and with regard to the toxicity, as you can see, and this is something expected, that TDM1 plus pertuzumab was less toxic in comparison to chemotherapy plus dual anti-HER2, at least in the neoadjuvant setting. And the overall quality of life and global health status, as you can see, TDM1 arm was superior to the chemo plus dual anti-HER2, specifically before surgery. After surgery, you can see there was no big difference between the two in the adjuvant phase. So to cut it short, the Christina study was a negative trial. And for me, it doesn't change practice. So there is no rule for TDM1 in the neoadjuvant setting so far based on this study. The second study that I want to talk about is the adaptive study, which is a German trial for hormone receptor positive, HER2 positive breast cancer. So those patients have been treated, randomized to 3 different arms: TDM1 alone, TDM1 plus endocrine therapy, or trastuzumab plus endocrine therapy. This is in the neoadjuvant setting, and this is for HER2 positive, hormone receptor positive breast cancer. They received a total of 4 cycles, as you can see. After that, they had the surgery, and chemotherapy was left optional for those who did not achieve. Actually, it was recommended for those who did not achieve PCR, while it is optional for those who achieve PCR. And as you can see, the PCR is the primary endpoint of the study. For those who received TDM1, you can see whether they received endocrine therapy or not. The PCR rate was in the range of 40 to 41%, to 41.5%, which is quite significant in a chemotherapy-free like kind of neoadjuvant setting. While those who received trastuzumab plus endocrine therapy, you can see that the PCR was 15.1, and it was statistically inferior in comparison to the TDM1 arms. Okay, if we look into the Christine study, which was presented a few minutes ago, the PCR was achieved by around 35% in patients with hormone receptor positive disease, like HER2 positive disease, treated with TDM1 plus pertuzumab. And these results, I mean, having like a PCR rate from 35 to 40% without use of neoadjuvant chemotherapy might support the hypothesis of de-escalating treatment with chemotherapy-free strategies in like selected patients. So if you have like elderly patient, cannot like tolerate chemotherapy, she has hormone receptor positive, HER2 positive, this might be like a treatment option that you can look at. So, but it's not a standard treatment, of course. So if we look at the, like from PCR point of view, those who achieve PCR, they had a better kind of disease-free survival in comparison to those who did not achieve PCR, which was statistically significant. And with regard to disease-free survival, as you can see, there is like no huge difference between the three treatment arms, TDM1 or TDM1 plus endocrine therapy or trastuzumab plus endocrine therapy. And the main reason, as per the investigators here, could be related to the adjuvant chemotherapy post-surgery, because as I mentioned, it was recommended for those who did not achieve PCR, and it was optional for those who achieved PCR. And once again, the distant-free survival was not significant between the three treatment arms. And once again, if we look into those who achieved PCR, whether chemotherapy did help those patients to improve the outcome, you can see that for those who achieve PCR, whether they receive chemotherapy or no chemotherapy, there have been no difference with regard to the outcome. So probably chemotherapy wouldn't add that much if PCR was achieved. Okay, so as a summary of the adaptive study, it's a positive trial given the fact that PCR, which is a primary endpoint, was achieved here, but it's not practice changing because simply because the treatment arms that have been included in the neoadjuvant setting is not a standard kind of treatment that we use for locally advanced HER2 positive breast cancer. Usually, at least till this point, we still consider using a chemotherapy backbone in the neoadjuvant setting. So the fact that you see that PCR, as we saw from the Christine and the ADAPT study, that those who achieve PCR, they had superior outcome in comparison to those who still have residual cancer. And there have been a very interesting publication in the Lancet 2014 trying to see the association between PCR and the long-term outcome, event-free survival, and overall survival. And you can see that those who achieve PCR, they had much better event-free survival, significantly better, and significantly better overall survival. This is for all breast cancer subtypes. However, if we focus on the HER2 positive breast cancer, we can see that that kind of association between PCR and event-free survival is even much stronger. So you can see the hazard ratio is 0.39. Look at here where you have HER2 positive, hormone receptor negative. The hazard ratio is almost 0.25. So there is a huge and strong association between PCR and the long-term outcome. And as you can see, there is unmet need for those who did not achieve PCR, or what we call residual cancer post-neoadjuvant chemotherapy. And this has created the rationale for the Catherine study, which is a landmark study that included those patients after having neoadjuvant chemotherapy, whether anthracycline was used or was a sole taxane chemotherapy, whether it was dual anti-HER2 or a single agent Herceptin. So of those patients, do they still have residual cancer? They have been randomized to receive TDM1 with the standard dose every 3 weeks for a total of 14 cycles versus trastuzumab for a total again of 14 cycles. And the primary endpoint here was invasive disease-free survival. 72.3% of those patients included were hormone receptor positive. 76.9% were given anthracycline in the neoadjuvant setting. 18% had received dual anti-HER2 blockade with trastuzumab and pertuzumab. So only minority here that received dual anti-HER2 in the neoadjuvant setting. So this is the primary endpoint of this study, and the invasive disease-free survival. And as you can see, that TDM1, the adjuvant TDM1 in residual cancer post-neoadjuvant chemotherapy, that the 3 years invasive disease-free survival was 88.3% versus 77%. So there was an absolute difference of almost 11.3%, with a hazard ratio of 0.50 and significant p-value, as you can see here. And most of the subgroups have benefited from TDM1 as opposed to adjuvant trastuzumab, including regardless of the hormone receptor status, as you can see, whether we are talking about hormone receptor status negative or positive, they both derive benefit of having adjuvant TDM1 in residual cancer post-neoadjuvant chemotherapy. Obviously, the toxicity profile was a little bit more in TDM1 arm in comparison to the Herceptin arm, but the most important ones were some liver like function abnormality and liver enzyme abnormality in the form of increased AST. Thrombocytopenia was still like a significant problem, towards like use of TDM1, and also the bilirubin was recorded to be higher in TDM1 treated patients. So as like a conclusion of the CATHERINE study of using adjuvant TDM1 in early breast cancer with residual like cancer post-neoadjuvant chemotherapy, I think this is a practice-changing kind of study, and this should represent the standard of care. And it was actually the representing standard of care since like 2 or 3 years ago. So the CATHERINE trial has completely changed the treatment algorithm for managing patients with HER2 positive early breast cancer by favoring even more the use of neoadjuvant approach in most of these cases. So nowadays, if we have a HER2 positive breast cancer, any primary tumor more than 2 centimeters, or any nodal, clinically nodal disease, we usually include them nowadays into neoadjuvant settings. So this will tell us about the biology of this HER2 positive breast cancer, and if this patient had residual cancer, might be like considered for adjuvant TDM1. The only exception, though, is those patients who have a stage 1 disease with tumor less than 2 centimeters, for whom the APT trial has shown a very good outcome using a very gentle chemotherapy, adjuvant chemotherapy, consisting of weekly paclitaxel and trastuzumab. As you have seen in the publication GCO by Sarah Tulani, that the outcome using adjuvant paclitaxel plus Herceptin in early stage HER2 positive breast cancer was really favorable. The 7-year disease-free survival, as you can see, was almost 93.3%. And this kind of benefit was consistent whether we are talking about ER or hormone receptor negative or hormone receptor positive. You can see that the 7-year disease-free survival was 90.7% for hormone receptor negative and 94.6% for hormone receptor positive. So all of these results have pushed us to use a de-escalating approach for stage 1 HER2 positive breast cancer. What about use of TDM1 in this kind of low risk setting? So this was another study by the same principal investigator, Dr. Sarah Tulani, using adjuvant TDM1 as a single agent for those who have early HER2 positive breast cancer, primary tumor like nodal disease negative or clinically node negative, and primary tumor of 2 centimeters or less. And they included almost 500 patients, and they have been randomized into like a 3-to-1 ratio using adjuvant TDM1 versus weekly paclitaxel plus Herceptin. As you can see, that 43% of those patients, they had even 1 centimeter or less like size of the primary tumor. You can see that 75% they had hormone receptor positive status, and 73% they tested positive for HER2 using immunohistochemistry of 3+ definition. You can see that the 3 years disease-free survival in the TDM1 arm it's almost 97.7%, which is really, really good one. You can see that that kind of benefit was also consistent, talking about hormone receptor positive, hormone receptor negative, 97.5%, 98.5% respectively. And also regardless of the primary tumor size, whether talking about less than 1 centimeter or 1 centimeter or more, 98.5%, 97.1% respectively. So these kind of results are really encouraging. If we look into the paclitaxel Herceptin arm in this study, the Attendee trial, you can see the 3 years disease-free survival was 92.8%. Remember from the APT trial, which have been published like 2 or 3 years ago, presented actually, the 3 years disease-free survival was in the range of 98.7%. So the rate of discontinuation from TDN1 was relatively high in the range of 23.5%. Actually, 9% of them only were related to toxicity that were protocol mandated. So there was some sort of frequent kind of discontinuation from TDN1, probably because of toxicity. If we look into comparison between the toxicity that have been reported between the 2 treatment arms, you can see that paclitaxel Herceptin arm, more neuropathy, more neutropenia, more infusion-related reactions, while TDM1, more thrombocytopenia, ALT, increased bilirubin, which is well known and consistent with the well-known side effects of TDM1 that we know from before. Cardiac toxicity, you can see that symptomatic heart failure, 0.8% for TDM1, 0.9% for paclitaxel Herceptin, while asymptomatic decline in ejection fraction was a little bit less in the TDM1 arm.
Ahmed, you have less than 2 minutes to conclude, please.
Yes, yeah, I'm concluding now. So the Attendee trial, you can see that adjuvant TDM1 in low-risk HER2 positive early breast cancer, I think it needs longer follow-up. We have only the 3 years disease-free survival, so we need a longer follow-up to see the long-term outcome. And given the fact that the safety and toxicity profile is not that significantly better than the paclitaxel Herceptin arm, and if you consider the financial toxicity also of TDM1 because of the cost, you might be a little bit hesitant to use it as a routine practice in the adjuvant setting for low-risk HER2 positive breast cancer. So in my opinion, and I think many of us might agree with that the best approach to early HER2 positive breast cancer would be the following. If you have a primary tumor that's 2 centimeters or less with clinically negative lymph nodes, I think patients should go for upfront surgery followed by adjuvant chemotherapy. And here we are talking about weekly paclitaxel plus trastuzumab. If you have a nodal positive disease or a primary tumor more than 2 centimeters, we may consider new adjuvant chemotherapy plus dual anti-HER2. If PCR was achieved, then we'll continue adjuvant trastuzumab plus minus pertuzumab if there was risk factors before starting the new adjuvant treatment, namely nodal positive disease. If residual cancer was still there post-surgery and post-new adjuvant chemotherapy, then adjuvant TDM1 is the right approach here. And I think this is the most important rule of adjuvant TDM1 or TDM1 in early breast cancer so far until today. I think with that I conclude and thank you for your attention.
Okay, thank you very much, Dr. Ahmed. And I don't know, Dr. Yassam, there is room for questions and answer, or?
I think we will keep the question to the end, and we have prepared very good panel discussion for you, so guys, don't escape, please. Now I'll invite, thank you, Professor Ghazali. Now I invite Dr. Bouhlega Talib to introduce the next session, the next topic and the speaker. Talib, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would welcome Dr. Nikki Levitt. She's a consultant medical oncology working in Oncology Department Cancer Center at Church Hospital, London, England. She's a famous doctor in her field in breast cancer. She had many publications. She will give us 2 talks. Dr. Nikki.
Thank you very much. I hope you can hear me. I'm just going to try and share the screen.
Okay.
Let me just get that.
Why you're wearing the hijab?
Actually, let's do it. So, all right, this way. And got it.
Okay, you can proceed now. So,
Right. Share. Okay. Are you able to see my slides and hear me?
yes.
I'm going to assume so. So first of all, I'd very much like to thank the organisers for inviting me to come and give these talks. The first of my talks is on adjuvant CDK4/6 inhibitors in ER-positive, HER2-negative breast cancers. Are we looking at something that will be of benefit or futility? So first of all, I just wanted to remind people with this cartoon that estrogen receptor activation can stimulate cyclin kinase complex to phosphorylate retinoblastoma protein. This is then released from the E2F transcription factor, allowing it to activate genes involved in cellular proliferation. We now have 3 drugs which are licensed blockers of CDK4 and 6, which are palbociclib, ribociclib, and abemaciclib. I wanted to mention very briefly the old data, which shows that these are extremely active drugs in the metastatic setting, both in endocrine sensitive and in the endocrine resistant setting. And when you look at the hazard ratios for efficacy, there's really nothing to pick between them. And there are also now overall survival data in addition. There are, however, some differences between the different drugs. Palbociclib was the first in class. It is highly specific against both CDK4 and 6. The main side effect is neutropenia, and in view of this, it's given with an intermittent dosing schedule of 3 weeks on and 1 week off. Ribociclib is similar and to palbociclib, but in addition, it does have some ability to cause QT prolongation and therefore requires ECG monitoring for the first few cycles. Ribociclib was the first of the agents to show an overall survival benefit, particularly in younger women treated with ovarian suppression. And then thirdly, there is abemaciclib, which is the most potent against CDK4 and 6, and also CDK9, which is again involved in cellular proliferation pathways. There are some data to suggest that abemaciclib is able to cross the blood-brain barrier, and it causes less neutropenia and is therefore able to be given on a continuous dosing schedule. In the UK, abemaciclib is commonly known as the diarrhea drug because of its main side effect, but it can also cause some significant fatigue. So given the excellent benefits seen in the metastatic settings with these agents, it is no surprise that the drug companies wanted to try and test them out in the adjuvant settings. And the 3 main studies are the PALACE study of palbociclib, which was a negative study published earlier this year, the MONARCH-E study, which tested abemaciclib, and finally the NATALIE study of ribociclib, which is still recruiting. So I wanted to start off just by going over the PALACE study, which was a phase 3 open label trial for patients with moderate to high risk ER-positive, HER2-negative breast cancer. Patients had at least 5 years of endocrine therapy and were randomized to an additional 2 years of full dose palbociclib or placebo. Patients could go on to the study if they were within a year of diagnosis and had to start the palbociclib or placebo within 6 months of having started on their endocrine therapy. And the primary objective was to compare the invasive disease-free survival rates between the arms. PALACE was a large study with over 5,700 patients enrolled, but quite a number of patients had relatively good outlook disease, and many of these patients will be cured by standard endocrine therapy alone. Of note in the PALLAS study, only 60% had high-risk breast cancer as defined by either 4 or more nodes positive or 1 to 3 nodes positive with either a large tumour or grade 3 disease. And the majority, over 80%, had received prior chemotherapy. At a median follow-up of just under 2 years, the invasive disease-free survival rates were incredibly similar between the two arms, 88.2% for palbociclib and 88.5% for endocrine therapy alone. And when they looked at the different subgroups, there was again no benefit observed from the addition of palbociclib. There were, however, toxicities. Grade 3 or 4 neutropenia was really significantly common. And there were also other toxicities, including fatigue, upper respiratory tract infections, and alopecia. And in view of these toxicities, I'm guessing mainly the neutropenia, over 40% of patients discontinued the palbociclib before the planned 2-year duration. And this was primarily due to adverse events. So the conclusion was that within the PALLAS study, palbociclib did not improve invasive disease-free survival compared to endocrine therapy alone. And as a result of this, the Data Safety and Management Committee stopped patients from carrying on with palbociclib in the treatment arm. I hope there will be further data to come out of this study, both clinical and translational, as time goes on. Before moving on to Monarch-E, I just also wanted to mention the Penelope B study, which is another adjuvant palbociclib study. This has had a press release saying that it is negative, and I anticipate that we are likely to hear more about it in the San Antonio meeting next week. This study randomized women who had residual disease after neoadjuvant chemotherapy to a year of palbociclib or not, with at least 5 years of endocrine therapy. And again, as I said, it's a negative study. I am slightly concerned that again, they haven't picked a very good group of patients to look at, in that we would expect most patients with ER-positive, HER2-negative breast cancer to have residual disease after neoadjuvant chemotherapy. I now want to move on to the Monarch-E study, which is the adjuvant study of abemaciclib, and was presented by Stephen Johnson in the plenary session at ESMO in September and published simultaneously in the JCO. They accepted that many patients with ER-positive, HER2-negative early breast cancer are cured by standard endocrine therapy alone, but accepted that those with high-risk disease do have significant early relapse rates of up to 20% in the first 10 years, and probably higher for the more significant disease, and therefore novel treatments are required. Abemaciclib, as we already know, shows good efficacy in the metastatic setting. So the Monarch-E study design took women with high-risk early breast cancer, and this was defined as 4 or more nodes positive or 1 to 3 nodes positive with either a large tumour, grade 3 disease, or a high Ki-67 score. So this was the entry criteria, as opposed to PALLAS, where only 60% of patients would have fulfilled these criteria. Patients were then randomized 1-to-1 for standard endocrine therapy or the addition of abemaciclib. And the primary objective was invasive disease-free survival. And of note, they had to start the abemaciclib much more quickly than was in the PALLAS study. This was a large, well-run study, and went from estimating that there would be a nearly 20% relapse rate within the first 5 years on the control arm. And the other thing to say about the statistics is that the analyses are event-driven. So although this first analysis has come out really very early in time, chronologically, it is driven by events rather than other enthusiasms. So this comes out at only just over a year and a quarter into each arm, and therefore over 70% of patients are still in their 2-year trial treatment period. Patient demographics show that, as expected, they were well balanced between the two trials. I think the only thing to pick out for is that a lot of these patients are young, a median age of 51, and 43% in each arm were premenopausal at diagnosis. Looking again at the high risk characteristics, approximately 60% of patients did have 4 or more nodes positive. Of the remaining 40%, they were split between large tumours, grade 3, and some having the high Ki-67 scores. The study also looked at the first endocrine treatment, and in 30% of patients, this was tamoxifen with or without ovarian suppression, and the remaining 70% roughly had aromatase inhibitors. Moving on to the results, this was a positive study, and the 2-year invasive disease-free survival rates were 92.2% with abemaciclib versus 88.7% in the endocrine therapy alone arm, which is a 3.5% absolute difference, or I find it easier to think of it as a 25% reduction in risk of abemaciclib. They looked at the pre-specified subgroups, and I think the only thing that I would point out is that there's maybe less benefit if this was a grade 1 tumour, but in the nastier tumours in younger women, that definitely was in keeping with the favour of abemaciclib. A secondary endpoint was distance relapse-free survival, and this was again statistically significant with a reduction in risk of 28.3%. And the other thing to note from this is that the curves seem to separate at about the 9-month mark. Therefore, if you are going to affect early relapse, you probably do need to get in early with these drugs. The location of distant relapses that were affected were particularly in bone and in liver. Other sites, there's not much data yet, so not much yet to choose between them. The duration on therapy seems fairly reasonable at the moment. I think the thing to point out here is that at this analysis, only 16.6% of patients on abemaciclib had discontinued treatment due to adverse events. Because 70% of patients are still on treatment, this figure will go up with time, but it is currently significantly lower than the over 40% who discontinued palbociclib in the PALLAS study. Quite a lot of patients have had dose adjustments, however. 60% have had some omitted doses and 40% have had dose reductions, which I think is no surprise given these drugs in the metastatic setting. Looking a little bit more at the adverse events, as I've said, abemaciclib is sometimes known as the diarrhea drug, and there were considerable rates of diarrhea, although only fairly small amounts of grade 3 diarrhea. There was also, as expected, more neutropenia and nausea and fatigue. However, some of the menopausal symptoms, such as arthralgia and hot flushes, were lower in the abemaciclib arm than in the endocrine treatment alone arm, and this has been seen in other studies as well, so although it's difficult to explain, it may indeed be real. Moving on, there are a couple of side effects of particular interest, I think especially in any adjuvant study, and those are of thromboembolic disease and interstitial lung disease, both of which are higher with abemaciclib than with endocrine therapy alone. And I think these will be important to look at as time goes on. As I've said, rates of grade 3 diarrhea were low and managed, and indeed the grade 1 and grade 2 diarrhea also fell with appropriate treatment. And so diarrhea over time was manageable, and fewer than 5% of patients came off study as a result of diarrhea. So in conclusion, abemaciclib combined with endocrine therapy showed a statistically significant improvement in invasive disease-free survival and also a recurrent in distant metastatic disease. And the safety profile was consistent with with what we already know about this drug. I wanted just to mention the Natalie study, which is still recruiting. This is the adjuvant study of ribociclib. In this study, they have actually gone with a lower dose of ribociclib than you would start out with in the metastatic setting, and they are opting to give that for 3 years. I think there are various reasons why this study is running behind the other two. There was a pause in recruitment to allow patients to be on adjuvant bisphosphonates, and then of course, COVID has not helped trial recruitment for anyone in 2020. And I think possibly in light of the monarchy data, the entry criteria have also been altered to try and increase the number of high-risk patients. So why are there such discordant results between PALLAS and monarchy? Well, clearly it may be that palbociclib and abemaciclib are truly different drugs in this setting. However, my feeling, given that they are so similar in efficacy in the metastatic setting, is that that is unlikely to explain the differences. And my suspicion is that it is due to different trial design. The two studies had very different entry criteria. As I've already said, PALLAS had a much higher percentage of lower risk disease, with only 60% of patients in the same high risk category as was in monarchy. In PALLAS, patients were started on trials much later after starting endocrine therapy, which may again make a difference if you're looking at early risk disease. And the discontinuation rate for palbociclib within PALLAS was very high, particularly in comparison to monarchy, although this will increase somewhat. And as George Sled commented, you can't benefit from a drug that you're not taking. There is a lot more that we need to know, not least, will the improvement in invasive disease-free survival carry out into turning into improved overall survival? I think we need to know more about toxicity, particularly these potentially life-threatening and life-changing side effects of thromboembolic and interstitial lung disease. I am hopeful that the translational aspects of these studies may help us to identify those who are either likely to benefit or not likely to benefit, so that we can narrow down those who actually need these drugs. We need to know what happens to patients when they come off study. The peak time for relapse from the ATTACK study was at the 2-year mark, which I think is why they chose 2 years of abemaciclib. We need clearly to know what happens to these patients in the few years following on after that. And also it will be very interesting to see whether these drugs have any effect on late recurrences. So are they of benefit or are they futility? I'm very optimistic about this. I think women with high risk disease have up to a 10% chance of recurrence within the first couple of years. And monarchy is the first study to potentially impact this and may possibly go on to improve survival from this disease. Despite the diarrhea, the toxicity remains manageable, and therefore I am extremely hopeful that this drug anyway is going to be of benefit to patients. And that's the end of my presentation.
Thank you, Dr. Nikki, for this nice lecture and update about the adjuvant and the role of CDK4/6 inhibitor. Can you proceed for the next lecture?
I certainly can. So I'll share screen again to move on to the next slides.
Okay.
So my second talk is on the Entour and SOLAR data. Is this practice changing in the management of, again, ER-positive, HER2-negative metastatic breast cancer? So a different cartoon showing essentially the same thing, that estrogen receptor activates the cyclin CDK kinase complex, phosphorylating retinoblastoma and stimulating processes towards cell proliferation. And on this side, I have put some of the drugs which are now the key players in interacting in this pathway. And I wanted just to go on and talk a little bit more about some of them. But before I do, I just wanted to mention about endocrine resistance, because I think this is vital when talking about the use of hormone therapies in metastatic disease. So we know that about 30% of ER-positive, HER2-negative early breast cancer patients will relapse. And that is thought to be due to endocrine resistance, which is divided into primary endocrine resistance, which is for those women who relapse within the first couple of years of starting adjuvant endocrine therapy, or within the first 6 months on first-line therapy for metastatic disease. Whereas secondary endocrine resistance is defined as relapse while on adjuvant endocrine therapy, but after the first 2 years, or after stopping adjuvant endocrine therapy within the first year, or in the metastatic setting after the relapse, but after the first 6 months of starting treatment. There are a lot of different suspected causes of endocrine resistance, but I just really wanted to highlight 2 of them, that ESR1 mutations, which ESR1 codes for the estrogen receptor, can cause acquired endocrine resistance, and also activation of the PI3 kinase mTOR signaling pathway is also thought to be a cause of endocrine resistance. I now want just to move on just to talk a little bit about those drugs which affect the estrogen receptor. So first of all, we have the aromatase inhibitors inhibiting the enzyme that converts androgens into estrogens, therefore depleting estrogen and therefore preventing the estrogen receptor activation of its target genes. Next, there are the selective estrogen receptor modulators, such as tamoxifen, which bind to the estrogen receptor, can activate, but then do not release the estrogen receptor for further use. And finally, the selective estrogen receptor degraders, such as fulvestrant, which bind to the estrogen receptor and then target it for cellular degradation. Fulvestrant really came more into use after the confirmed study, which showed that doubling the dose to 500 milligrams as opposed to the previously used 250 milligram monthly dose did actually give useful progression-free survival advantage. And since then, we've come to see that fulvestrant really comes into its own when there are mutations to the estrogen receptor. And this autumn, there was a combined analysis of the SOPHIA and EFFECT data. In both these trials, women who had already had exposure to an aromatase inhibitor were randomized to either exemestane or exemestane with fulvestrant, or in SOPHIA, exemestane and fulvestrant. And ESR mutations were found in about 30% of baseline samples. And when they analysed the data, it was the patients who had these ESR1 mutations who had improved progression-free survival with fulvestrant compared to exemestane. And I don't think anyone's going to jump with excitement over improved survival from 3.9, or improved progression survival from 2.4 to 3.9 months, but it was significant. And the 1-year overall survival was higher in this group, 80% with fulvestrant compared to 62% with exemestane. However, patients who had wild-type ESR1 mutations, they didn't see any improvement in progression-free survival. And my point really is that in metastatic ER-positive, HER2-negative breast cancer trials, the hormone backbone matters. And one needs to look at the things like the ESR1 mutation to try and tease out what is due to any additional drug and what is due to the backbone. We know that fulvestrant, although beneficial, runs out of use after multiple lines of hormone therapy. Response rates are low, typically less than 10%. In vitro data show that multiple lines of therapy increase mutant cell lines, which are not so sensitive to fulvestrant. And we are all aware of the difficulty of administration of this drug with monthly IM injections and the low bioavailability. Therefore, for quite some time, new SERDs have been required. And I just wanted to mention elacestrant, which is a novel non-steroidal orally bioavailable SERD. In vitro, it does show activity against these cell lines that are not so sensitive to fulvestrant. And in phase 1 studies in heavily pre-treated patients, there were response rates around 27%, which I think is quite exciting phase 1 activity. The main side effect appears to be nausea. The EMERALD-3 study has been set up to look at the to look further at this, and it is a phase 3 study of elacestrant versus physician's choice of therapy in patients with ER-positive, HER2-negative breast cancer following 1 or 2 lines of endocrine therapy, but all patients will have received a CDK4/6 inhibitor, and I think this is very important, and this trial is ongoing. Again, I'm just going to mention the CDK4/6 inhibitors. I showed you the slide a moment ago, just to say that there is good activity in the metastatic setting, and these drugs, I think, remain the standard of care for relapsed ER-positive, HER2-negative breast cancer in both the endocrine sensitive and endocrine resistant groups. So the main question is, what do we do next? And I now want to move on to talk about alpelisib, which is a reasonably novel PI3 kinase inhibitor. The SOLAR-1 data has looked at the addition of alpelisib to fulvestrant, and the initial results were presented in, I think, ASCO 2019, and showed a benefit in progression-free survival. And in view of this, they went on to look at overall survival, which was presented in this year's ESMO. So just to talk a little bit more about the study, approximately 40% of patients with ER-positive, HER2-negative advanced breast cancer carry mutations in the PIK3CA gene that encodes a subunit of the PI3 kinase protein, and this is associated with poor prognosis and survival. Alpelisib is an inhibitor of PI3 kinase, and we know from the earlier presented data that it shows efficacy with fulvestrant. It improved the median progression-free survival from 5.7 months to 11 months. And in view of this, they have gone on to look at overall survival analysis. So the study enrolled men or postmenopausal women with recurrent or progressive disease after an aromatase inhibitor. The cohort we're looking at all had PIK3CA mutations, and patients were randomized 1-to-1 to fulvestrant with either alpelisib or placebo. And overall survival was a key secondary endpoint. My notes about SOLAR-1 are also just to point out that patients were excluded if they had had any chemotherapy for metastatic breast cancer. Neither were they allowed in if they were on ovarian suppression or had had ovarian radiotherapy to render them postmenopausal. Patients were not allowed on if they had had a previous mTOR inhibitor or if they had diabetes. And I think importantly, when looking at survival data, it's important to note that patients were allowed to continue on the fulvestrant if they had stopped alpelisib, and there was a 25% discontinuation rate for alpelisib, mainly due to adverse events. The median age of patients on this study was 63, and the vast majority were endocrine resistant. The most important thing to note, perhaps, about this study is that this patient group, fewer than 6%, had had exposure to a CDK4/6 inhibitor, and therefore this population probably does not really represent a patient group that we see very much at present. The overall survival analysis was event planned. It was an event-driven analysis after approximately 178 deaths. And at this data cutoff, as you can see, the vast majority of patients on either arm had come off treatment, and most of that was because of disease progression. Moving on to the overall survival data, this showed a numeric nearly 8-month improvement in overall survival for patients on the alpelisib arm, but it did not reach statistical significance, and the confidence interval went up to greater than 1. When they looked at other subsections, subgroups of the data, I think you can see that it's reasonably in line across most of the subgroups, with possibly less benefit being apparent in patients who had either bone-only disease or who didn't have lung or liver metastases. When they looked at those who did have lung or liver metastases, again, there was a numerical improvement in survival, but it was, again, not statistically significant with a CI interval going up to 1. They also looked at patients in whom they could detect circulating tumor DNA containing the PIK3CA mutation. And it's, again, the same story with a numerical improvement in overall survival, but it, again, is not statistically significant. They went on to look at what patients went on to after discontinuing study medication. And I would say that I think these look pretty balanced between the two arms. About just over between 10 and 15% went on to have a CDK4/6 inhibitor as their next line. And obviously a certain number will at some stage have gone on to chemotherapy. And when they looked at the time to first chemotherapy, they did get a statistically significant result with a delay of 8.5 months for those who had had alpelisib. Moving on to toxicity, that was very much as we would expect with this agent, with significant rates of hyperglycemia and diarrhea, and also quite a significant rate of rash, although this was not usually high grade. I also just wanted to point out that I think that there's quite a low level of stomatitis, certainly in comparison to Everolimus, which we're quite familiar with. So the conclusions were that the addition of alpelisib to fulvestrant gave a numeric but not statistically significant increase in overall survival, and that carried through to the subgroups of lung or liver metastases and those with circulating tumor DNA mutational changes. They did point out that it delays time to first chemotherapy, and that that this supports the data from that this is supportive of the use of alpelisib. However, as I've already said, fewer than 6% had had a prior CDK inhibitor treatment, and in that group, the median progression-free survival was only 5.5 months compared to 1.8 in the placebo arm. So clearly the problem with this is that it is not really looking at the patient group that we have in front of us in clinic, but we do have a little bit more data from the BES study, which was an open label phase 2 study, which was presented at ASCO this year. And again, I'm only looking at the black boxes. This study was for men or postmenopausal women with advanced ER-positive, HER2-negative disease. And in this group, all the patients had had exposure to a CDK4/6 inhibitor. And the primary endpoint of this study was the proportion of patients who were alive without disease progression at the 6-month mark. The patient characteristics were very much as you would expect, with good performance status patients, and with 100 patients eligible with measurable disease. The majority of patients had had one line of prior therapy in the metastatic setting, and for most of those it was endocrine therapy, but a small number of patients had had chemotherapy. And this was a positive study, and they found that just over 50% of patients had not progressed at the 6-month mark, and the median progression-free survival was a little bit longer than that at 7.3 months. This compared reasonably with that small cohort of patients with both a PIK3CA mutation and prior CDK exposure within SOLAR-1. The response rates were, I think, very much as you'd expect, not terribly exciting, but with better clinical benefit rates. And these are the waterfall plots for the BYLieve study and for the similar cohort from SOLAR-1, showing some benefit. And again, from BYLieve, the expected toxicities were seen: hyperglycemia, diarrhea, and rash. But there were also some data to suggest that with alpelisib, if you give upfront antihistamines, you can both reduce the severity and possibly the frequency of rash. The other thing just to say about the discontinuation data was that in SOLAR-1, just over 6% of patients discontinued treatment because of hyperglycemia, whereas that dropped to 1.6% in the BYLieve study, which may just represent better familiarity with these drugs and investigators feeling more confident about how to manage it. So in conclusion, BYLieve does demonstrate clinically meaningful, perhaps, efficacy with the addition of alpelisib to fulvestrant in this patient population. And it is in line with the small number of patients from SOLAR-1 in this setting, and does support the use of these agents in this line of therapy. I was asked to include a little bit on Entour inhibitors. I'm afraid I can't find anything very new to tell you about, but just to remind you that Everolimus was very exciting 8 years ago when it came to our attention from the Bolero-2 study, which showed a 6-month improvement in progression-free survival for the combination of everolimus and exemestane after a non-steroidal aromatase inhibitor. The toxicities of everolimus are well known, particularly mucositis and hyperglycemia, but with a significant and worrying amount of pneumonitis seen. And exemestane and everolimus became the standard of care second line after an aromatase inhibitor until the advent of the CDK4/6 inhibitors, when it was promptly knocked off that slot. I've looked to see if there's any data for the use of everolimus and exemestane for patients who have been exposed to CDK4/6 inhibitors, and I think at present there's very little good data out there. I found one retrospective study of 33 patients, 17 of whom had had prior CDK4/6 inhibitors. And in this retrospective study, there didn't seem to be any difference in progression-free survival or overall survival between those who had or hadn't had CDK4/6 inhibitors. So I guess it is a reasonable thing to try. There were no data on endocrine resistance, and my feeling is in this population is really whether exemestane is likely to have much efficacy with or without the everolimus. So moving on to my conclusion, are the data on mTOR inhibitors and the SOLAR data practice changing? And I feel a bit equivocal about this. I think maybe they are certainly part of the jigsaw. I actually think that the next thing that's really going to impact this group is going to be the input of the development of personalized medicine with liquid biopsies, which I hope will be able to predict those patients who need to move to a SERD rather than an aromatase inhibitor, and those who carry the PIK3CA mutations, and therefore who may get benefit from the PI3 kinase inhibitors. I think that CDK4/6 inhibitors are set to stay as our first and or second line treatment in this disease. And I think we are absolutely crying out for decent efficacy trials to look at the patient population after that. And that's the end of my second talk.
Thank you, Dr. Nikki, for this nice lecture and update about the endocrine resistance. We will move to the next topic with Dr. Sharif Sammani. He's a medical oncology. He's a consultant medical oncology working at King Abdullah Medical City at Mecca. We are running behind the schedule, so the mic for you, Dr. Sharif.
Thank you very much, Mr. Chairman, and thank you very much for the nice invitation from the organizer. And I would like to congratulate you for the very successful meeting. So first, can you see my screen?
Yes, go ahead.
Okay. So my topic today is to talk about how to manage bone metastasis in patients with hormonal receptor positive breast cancer. With a special focus on metastatic patient, of course. As you know, bone metastasis is quite common in metastatic breast cancer. And if you look to this diagram, you can see that in patients with metastatic breast cancer and as well in prostate cancer, 65 to 75% of metastatic patients have bone metastasis. And you know, bone metastasis is not always indolent. It may be coupled with some serious sequelae, like having pathological fracture, spinal cord compression. Patient may need radiation to the bone or surgery to the bone, and collectively these four events are called skeletal related events. And we have data from this population-based study from Denmark and others as well, that patients with bone metastasis, and in addition they have skeletal related events, they have worse survival outcome compared to patients having bone metastasis but without these events. So it's quite important to prevent those sequelae of bone metastasis. So this is the agenda of my talk. Briefly, we'll talk first about the biology of bone metastasis in patients with breast cancer. As you know, with the start of having cancer, some of the malignant cells may home into bone marrow niches, and then they may keep quiet for a variable duration of time, and then for a variable reason, for whatever reason, these malignant cells will escape from quiescence and start to be activated, start to proliferate, and will lead, it will end up by having clinical bone metastasis. And you know, normally there is normal bone turnover, but it's under tight control. Actually, we have osteoblasts and osteoclasts. Osteoblasts are responsible for bone formation, while osteoclasts, as we know, are responsible for bone resorption. And normally osteoblasts will release what's called rank ligand. And when this rank ligand will bind to rank on the surface of the osteoclast, osteoclasts become activated. It will activate bone resorption to a limited extent, and then the usual bone turnover will proceed. And this is, as we said, is under tight control in response only to physiological stimuli. However, with the development of metastasis to the bone, the osteoblasts start to release excessive amounts of rank ligands. And this excessive release of rank ligand will activate the osteoclast. So bone resorption will predominate. And in addition to bone resorption and lytic lesion in the bone, this resorption will release as well some growth factors from the bone matrix. And these growth factors will stimulate the growth of bone metastasis more and more. So a vicious cycle will go ahead. So this is how things will go when bone metastasis will develop. So we have a variety of bone modifying agents, and they are active in patients with bone metastasis in a variety of tumors, and will focus on breast cancer. So we have two major classes of bone modifying agents. The first is biphosphonate, and the next is rank ligand inhibitors, mainly denosumab. So for biphosphonate, we have different agents like pamidronate, zoledronic acid, clodronate, ibandronate, which shows efficacy against bone metastasis. Some agents are not tested for patients having bone metastasis, usually used only for prevention of bone loss. And we have as well the only agent that's available currently in the practice for rank ligand inhibitor is denosumab. They work by to some extent a different mechanism of action. If we go first for denosumab is a rank ligand inhibitor. That is to say, it prevents a binding between the rank and the rank ligands on the surface of the osteoclast. So the osteoclast will not be activated, so it will stop bone resorption. On the other hand, biphosphonate work by a different mechanism. They are taken, ingested by the osteoclast, and once ingested, they will lead to apoptosis, and osteoclast will not be functioning, and bone resorption will be arrested. So this is how the two major classes of agents work in patients with bone metastasis. So we have data, we'll start with denosumab. We have data about the activity of biphosphonate in patients having bone metastasis. Previously, several years back, maybe 20 years or more, we have pamidronate and other agents only approved for patients with bone metastasis till the introduction of zoledronic acid, and zoledronic acid was compared with pamidronate in a non-inferiority trial in patients having advanced breast cancer or multiple myeloma. And this is the data from this trial, and we can see clearly that zoledronic acid decreased the risk of skeletal morbidity by about 20% compared to pamidronate. And since this study, zoledronic acid was the favorable agent of choice for treatment of patients having bone metastasis, given the first better outcome in relation to decreasing the bone morbidity. And in addition, it is an agent that can be given with injection every month at that time, compared to the long-term use of oral agents. And we know the issue of compliance with long-term oral medication. So this study was conducted in Western population. And in addition, we have another study that was conducted in Japan. In Japan, pamidronate was not approved for treatment of bone metastasis. That's why when they started to investigate for the activity of zoledronic acid, they tested zoledronic acid against placebo because they did not have pamidronate approved at that time. And this is the outcome of the study, where patients who received zoledronic acid compared to placebo have lower incidence of skeletal-related events, and lower incidence of fracture, lower incidence of the need to do radiation or surgery to the bone. And if you look to the right side of the diagram, the frequency of skeletal-related events is decreased by about 20% in patients who received zoledronic acid compared to placebo. So even in the Japanese or Asian population, this is still working. The next question that have been answered is, initially zoledronic acid is given every 4 weeks. However, will be fine to give zoledronic acid over a wider interval compared to the 4-weekly interval. This has been assessed in several trials. We have some trials, I will not present here, that investigated the approach of giving 12 months of monthly zoledronic acid followed by zoledronic acid every 12 weeks compared to the standard at that time of 4-weekly regimen. And we have this trial where patients received zoledronic acid every 4 weeks compared to zoledronic acid every 12 weeks. And I think you can see clearly in this diagram that the risk of skeletal-related events is more or less the same between the two regimens. However, we need to keep in mind something which is important. In the 12-weekly schedule, higher number of patients require the surgery to the bone. And this is something that we need to keep in mind for some patients, especially patients having extensive bone metastasis. Moving to denosumab, we have 3 identical trials that assess the value of denosumab compared to zoledronic acid in a non-inferiority design in patients with advanced breast cancer, advanced prostate cancer, and in addition in patients with other solid tumors and multiple myeloma. And more or less we can say the outcome of the denosumab compared to zoledronic acid in the 3 trials more or less similar. In breast cancer, you can see this is a primary endpoint on the left side, which is time to first on study skeletal related events. And and you can see that we have patients without skeletal-related events for 27 months in the denosumab arm compared to 19 months in the zoledronic acid arm. So it seems that we have better outcome with denosumab compared to zoledronic acid. And on the right side of this diagram, the total number of events is quite higher in patients on Zometa compared to patients with treated with denosumab. Compared to patients treated with denosumab, decreased the number of total skeletal-related events compared to zoledronic acid. So what I need to highlight from this forest plot is even in patients with higher tumor burden or lower tumor burden, the outcome is in favor of using denosumab, as you can see in this forest plot. And in addition, patients having visceral metastasis or not having visceral metastasis, still denosumab have better outcome in terms of preventing skeletal-related events compared to zoledronic acid. So we have seen the value of or the validity of using a 12-weekly approach of zoledronic acid. What about other agents? So to assess longer interval of using other bone-modifying agents, we have this study that had been presented in ESMO Breast Cancer, I think last year. And in this study, patients were having breast or prostate cancer and having at least one site of bone metastasis were randomized into a 4-weekly regimen of bone modifying agents of their physician choice of zoledronic acid or denosumab or pamidronate versus the 12-weekly approach. And both arms received treatment for 1 year. And if you looked with this table, we can see clearly that the number of patients is quite small. And for the denosumab arm, only about 60 patients were enrolled in the study, 31 in the 4-weekly and 29 in the 12-weekly regimen. So this is a very small study, and we need to keep this in mind. However, the primary endpoint, which is the health-related quality of life, is quite similar between the two treatment regimens. Other endpoints like symptomatic skeletal events and pain and so were almost the same between the two approaches, 4-weekly and 12-weekly approaches. However, again and again, I need to emphasize that this is a very small study, and I think we cannot derive definite conclusion of wider interval of denosumab, for example, from this study. And I think we need to take these results with caution. So what is the recommended approach according to the ESMO guidelines 2020 for the treatment of patients with having bone metastasis? If the patient having oligometastatic disease, they recommend to initiate zoledronic acid every 12 weeks, 3 monthly. And they even recommend to consider stopping treatment after 24 months of therapy if the patient having good tumor control. However, in patients having multiple bone metastases or more extensive disease, they recommend using either zoledronic acid or denosumab. And at that time, they recommend to start with for 3 to 6 months of monthly regimen, followed by de-escalation in patient having good response to therapy after 6 months to 3 monthly regimen of zoledronic acid. This is a recommendation from ESMO 2020 guidelines. So I will have a quick hint about other indications of bone modifying agents, like their utilization for preventing medication-induced bone loss in breast cancer. I will present one study for a patient treated with denosumab versus placebo. And in this study, denosumab decreased the risk of fracture by about 50%. The hazard ratio is 0.5. And we have data as well for zoledronic acid in similar scenarios from the ZOFAST trial from Austrian Breast Cancer Study Group 12. And we know that zoledronic acid as well decreased the risk of bone loss in a significant way. So both medications are working in preventing treatment-induced bone loss. And this is again the ESMO recommendation, where you should, when you are giving the patient treatment that are chronic endocrine treatment that's known to accelerate the bone loss, you need to assess the bone mineral density. And if the T-score is less than -2, it's recommended to start treatment by denosumab or biphosphonate therapy, in addition, of course, to calcium and vitamin D. However, if you have a T-score less than minus 1.5, in addition to other risk factors like smoking, like chronic use of steroid, older age, or history of fracture. So still you can use the same approach. However, if you don't have these risk factors and T-score is more than -2, only calcium and vitamin D is recommended. The last point that I need to highlight is, do we have data about using bone modifying agents in early breast cancer, adjuvant or neoadjuvant? Why we are interested in exploring those agents in early breast cancer, not in metastatic patients? We have data, at least from preclinical studies and preclinical models, that denosumab, for example, can decrease the risk of tumor migration, invasion within the related tumor environment. This is for denosumab. For zoledronic acid, different mechanisms of anti-cancer activity have been postulated, including decreasing the increasing apoptosis, decreasing tumor migration, decreasing the invasiveness of the tumor, and so. Excuse me.
Did you finish, Dr. Sharif?
No, not yet, not yet. I received the call. I need to stop that. Excuse me for this inconvenience. I'm sorry. So we have different mechanisms that have been postulated for the anti-cancer activity of zoledronic acid and denosumab, and that's why they have been investigated as well as an adjuvant therapy in patients who have no metastasis as well. We have, for example, if we start with biphosphonate, we have different studies that address the adjuvant use of different medications or different types of biphosphonates. And they included premenopausal, postmenopausal patients, hormonal receptor positive and negative. And we have variable duration of treatment, 2 years, 3 years, 5 years. So these studies actually are heterogeneous studies. However, we have a big meta-analysis that addresses the value of adjuvant biphosphonate, which included more than 18,000 patients. And the majority of patients are postmenopausal, and majority as well were hormonal receptor positive. And 50% of patients included in this meta-analysis received zoledronic acid. And this is the outcome of the meta-analysis. Overall, the benefit is quite small. However, if we restrict the assessment for postmenopausal patients, we have decreased breast cancer mortality by more than 3%, 3.3%, and distant recurrence by 3.4% in postmenopausal patients, or patients who received ovarian suppression. So after this meta-analysis, we can say that adjuvant biphosphonate is beneficial in postmenopausal patients, and it has been said that this 3.3% reduction in breast cancer mortality after over 10 years is quite similar to the value of anthracycline compared to older chemotherapy regimens like CMF. So we have value in postmenopausal patients. So the next question is, which agent to use? Is it zoledronic acid or oral agents? So we have this SWOG trial, which included more than 6,000 patients, and they randomized patients with a stage 1 to 3 breast cancer into clodronate, ibandronate, or zoledronic acid for 3 years. And we can see clearly from this diagram that the disease-free survival and overall survival are similar between the 3 agents, and you can use each of them. However, long-term use of oral medication is quite challenging. The compliance with oral medication is quite challenging over a long time. If we move to the value of denosumab as an adjuvant therapy, we have 2 big trials. The first is DCARE trial, including pre- and postmenopausal patients. And it is not restricted to hormonal positive. It's including hormonal positive and negative, and it is a negative trial. No value in terms of survival outcome in favor of giving denosumab. However, we have another trial, which is the Australian Breast Cancer Study Group 18, and it seems that we have some benefit with denosumab, adjuvant denosumab, 60 milligram every 6 months, about 3% improvement after 8 years. However, still, this is not popular to use in the routine practice, still not recommended, because when they looked for the main driver of this improvement of survival, it was non-breast cancer recurrence. So non-breast primary recurrence. So it's still not popular to use adjuvant denosumab. Do we have data in the neoadjuvant setting? We have one study with zoledronic acid in addition to standard neoadjuvant chemotherapy, and it is negative in terms of disease-free survival. We don't have value. If we move to another study with denosumab, not zoledronic acid this time, denosumab, just presented in a virtual ESMO 2020 called X trial, where patients were randomized into nab-paclitaxel followed by AC plus or minus denosumab. They tested different treatment schedules of nab-paclitaxel, but this is not our point. Patients were randomized into chemo plus or minus denosumab. We can see clearly that there is no difference in terms of PCR with the use of denosumab versus no denosumab. And what's alerting for me, this study included hormonal receptor positive, HER2 negative, HER2 positive, and triple negative. And if you look to this diagram, you can see that the rank ligand, the rank tested by immunohistochemistry is quite more common in patients with hormonal receptor positive, HER2 negative compared to the other subtypes of breast cancer. So shall we have a different outcome with the use of denosumab if we have a study dedicated for this category of breast cancer patients? To answer this question, we in King Abdullah Medical City will initiate this study in premenopausal patients with breast cancer, ER/PR positive, HER2 negative with allergy score 6 to 8. Those patients will be randomized into standard chemotherapy plus or minus denosumab. We got our IRB approval, and we got last month's Saudi FDA approval as well, and we'll launch, inshallah, soon this study. So I will conclude by saying that we have different bone-modifying agents that have been shown to decrease skeletal-related events and other sequelae of bone metastasis. And zoledronic acid every 3 months is maybe more convenient, especially in patients with oligometastasis. Denosumab subcutaneous is an attractive option, maybe more effective. It can decrease skeletal-related events compared to zoledronic acid by about 17%. However, which agent to use, we can discuss that, but we need to keep different factors when choosing the agent to use. It is the cost, availability, renal function, convenience, and others. And for prevention of bone loss, I think in postmenopausal patients, I prefer to use zoledronic acid because of the extra value of the extra survival benefit as an adjuvant therapy of zoledronic acid, which is not clearly demonstrated with denosumab. And we have evolving data about the new adjuvant therapy of bone-modifying agent. Thank you very much for your kind attention.
Thank you very much, Dr. Sharif. I'd like to invite all the panelists and the speakers, please, to turn on their cameras and mics. We have loads of questions, and I will address all questions to all panelists, please, so you can just have a share in answering them. I will start with the attendee questions. We have so many questions. The most active, actually, person in the discussion is Dr. Muhammad Mahmoud. Welcome, Dr. Muhammad Mahmoud. You have more than 12 questions. Thank you. You made our day. So we'll start with the HER2 positive disease. We will go in by order of the presentation. So Ahmed Al-Shehri is here. Dr. Levet is with us also. Okay, Ahmed, and also the question will go to everybody. A question was asked is that what will you do after progression on the, we have tried, for example, in the neoadjuvant setting, you have given Herceptin, pertuzumab, and then the adjuvant setting when patient had a pathological remnant disease or residual disease. You have, what will you do after that? You have used TDM1, you have used Herceptin, you have used pertuzumab, then what you will do?
Yeah, excellent question, actually. It depends on the disease-free interval. So probably if we are talking about more than 12 months of disease-free interval, we might elect to go to one of these prior lines that have been used. I will be like encouraged to use like dual anti-HER2 plus chemotherapy with docetaxel, paclitaxel, vinorelbine, like similar to the Cleopatra approach if we have more than 12 months of disease-free interval. If we have like a short disease-free interval, like immediate relapse after we finish TDM1, as we face in few patients, unfortunate patients, In that case, this patient will be refractory to all these lines of treatment. I would consider something like one of these new combinations, like, for example, tucatinib plus capecitabine and trastuzumab might be probably the best treatment option nowadays. So if it's a short kind of disease-free interval, I'll consider this combination of tucatinib, capecitabine, Herceptin. If it's like long disease-free interval, like more than a year, for example, I would go back to one of these prior lines, and probably I would go with the Cleopatra approach again.
Okay, Professor Levet?
I would completely agree. We don't actually have access to tucatinib in the UK at present, but I'm quite excited about being able to use it when we can. So nothing more to add. Completely agree.
Is it raining in Oxford now?
It's not raining in North Oxfordshire, I can tell you that.
Yeah. Because whenever Dr. Sharif said I can see, I would tell him I can't see clearly now, the rain is gone. Dr. Hisham?
Yeah, I completely agree with Dr. Sherry, but usually it is very important to know that it is usually to go for the best ever treatment from the start. So I know it will be difficult later on, but it's will be beneficial to those patients usually in the high risk population to start with the doublet treatment with the Herceptin and pertuzumab, and then who are not achieving a pathological complete response to go for TDM1. So it is very, very important not to look to the bad side, but to look to the very good side. And later, so we may go for a new analysis using the sequencing facility to know if there is any other mutation coming, so we can more to personalize the treatment later.
Sharif?
I totally agree with Dr. Sherry. I will use the same approach. It depends on the interval of treatment till the patient has relapse. I totally agree.
And Talib, I do believe you will agree because I agree with the Sharif. Okay. Now, this actually, the mentioning about tucatinib brought us to another question by the same gentleman, that tucatinib plus Herceptin is of significant activity in the heavily pretreated patients with CNS involvement. And so, do you think that it might be a better approach rather than to step into the first line or the patient with de novo metastatic disease? It might be more active, especially we know that the percentage of brain involvement with HER2 positive disease is almost nearly about 25%. I would start with Professor Levet, please.
Sorry, would we bring tucatinib up front?
Tucatinib, Herceptin up front rather than use in a clinical trial setting, of course.
I think it's a really interesting agent, and I think I have certainly seen efficacy of lapatinib and capecitabine with cerebral metastases in the HER2 positive setting. So I think there's great hope that we're going to see good benefit from tucatinib, which certainly looks to be more active. So I think it's very difficult to talk without more actual trial data, but I'm optimistic that this is going to be a really useful.
So let me put the question in another word to the other guys. Do you think that we have now here an hypothesis generating question that we may actually adapt in the future into exploring this? Ahmed or Dr. Hisham, please.
Yeah, I think it the management of the CNS involvement in heavily pretreated population, or the CNS involvement population is very interesting, especially that we have a lot of data for TDM1, and now the tucatinib, we may go for neratinib in combination with the TDM1. So it is very important. We don't know which is better, but it is very, it is like to see some patient with CNS metastasis, especially with those with leptomeningeal infiltration. I think it's very important to discuss this issue and this subtype of population, more focusing on them. So yes, it is challenging, and we cannot, as Levet said, We cannot go for like a conclusion without definite trials. But all these agents are active. The tucatinib seems promising, but we are waiting more mature data and in practice assessment of this agent.
Ahmed?
Yeah, I totally agree with everybody comments, specifically with you, Issam. I mean, maybe in the future, we can consider like a clinical trial, including those with CNS metastases, because we know that previously CNS metastasis was one of the exclusion criteria in most of these clinical trials. So if we have such a trial comparing head to head, like the standard of care, which is Cleopatra in the first line setting, plus like versus the other combination, including CNS metastatic disease, then we have the definite answer for that. But for now, we'll stick to the order of using the tucatinib combination in a third line setting.
Sharif?
Yeah, I agree with you. Always, you are giving me the question at the end, so I have nothing.
I will start now with you.
But I will add something. Dr. So just we need to be cautious here. Of course, this is very exciting data from the tucatinib, and we have the Occitan as well, but they have been testing patients who received at least two previous lines of treatment. We need to keep in mind that previously we have data in second line of TDM1, okay? However, when we have the TDM1 first line data in metastatic HER2-positive disease in the Mariani study compared to taxane Herceptin, there is no difference, okay? So it is not essential that treatment which is superior in previously treated patients will show the same activity to be superior in first line. So I agree with previous colleagues that we need to have a trial to test this approach in first line.
Okay. So now this goes to you, Sharif.
Is a question, please.
It's about the use of Everolimus or the mTOR inhibitor in general in breast cancer and their bad reputation of being very badly tolerated in the past. So what's your view about it? And we know that it might represent an option after progression on CDK4/6 inhibitors compared to Penelope and the others. So what do you think about this?
Thank you very much for the question, Dr. Assam. You know, I think Everolimus was introduced in the market, at least in Saudi Arabia, in 2012. Okay, so in the first few years, most of us have bad experience with Everolimus. We don't know how to deal with it. We don't know how to choose the best treatment the best patient for that treatment. However, at least in my own my simple experience, after 1 or 2 years of treating patients with Everolimus, I got learning curve how to manage, how to choose the patient. So my suggestion is, first, please don't choose patients who are diabetic. It will be difficult to control them. And we need to be proactive in using mouse formula, including dexamethasone and so on. With this, with a good choice of patients in good performance status and earlier use of treatment, not to leave it for patients who are heavily pretreated, we can have some good outcome and good toxicity profile with Everolimus when choosing the correct patients. And this issue will come as well, Dr. Assam, with alpelisib. Alpelisib may be a good option, but it's not an easy medication. And if you look to the data, even the hyperglycemia is much higher compared to Everolimus. Everolimus, we have more mucositis, but alpelisib, we have more hyperglycememia. So I think it will be a learning curve. In the first few patients you are going to treat with alpelisib, please choose them very, very carefully and have close eye on those patients, at least in the first few weeks of treatment.
Professor Levitt, what's about the use of Everolimus in the UK, and what is your experience based on the side effects?
Well, exactly as Dr. Sharif said, when it was our standard of care, I used it a lot in a lot of patients, and actually generally have found the toxicity very manageable. I think quite a significant percentage of patients need dose reductions, but then do manage to stay on treatment, and I quite like the combination. I use it a lot less now that the CDK4/6 inhibitors have come in, and particularly because in the NHS, we're not allowed to use CDK4/6 inhibitors if patients have had Everolimus. So it really has moved to the other setting, just beginning to use it in the post-CDK4/6 setting, but I don't think I've had sufficient patients to have a real feel for how much benefit it's going to be.
Professor Ghazali, what's your experience in Egypt with the same matter? I believe we and the Egyptians, we are almost the same. So
yeah. So I think I don't like the Everolimus very much, and I think I think because the feeling from the start that we are treating like hormonal treatment, we was expecting that we will have a very mild side effects. So and then we face the hyperglycemia, stomatitis, pneumonitis, and so it is like as Sharif said, we have starting the learning curve and try to go for management of the side effects. But still, it was like a good news when we have the CDK4/6 inhibitors and very manageable side effects, less side effects. So the positioning usually of the mTOR inhibitors now is positioned later, but with the presence now of the PI3K inhibitors, so the question coming again. So you want to go for to drive or to move this PI3K in the front line or to keep them in the back line. And this is very important, especially the data evolving now. And we must assess the mutation from the start or not to assess the PI3K from the start, to start with them or to keep them at the end.
Thank you. Dr. Ahmed Shahri?
Yeah, I totally agree with everyone. I had, like at the beginning, I faced some problem with regard to managing side effects of Everolimus. As Dr. Sharif clearly said, there was a learning curve. Nowadays, actually, because of the accumulative kind of experience with all these patients, and I would add to what Dr. Sharif said, with the proper selection of patients, also the aggressive supportive management of these patients, especially the mucositis, which was like a really major problem for a lot of patients. Nowadays, with the use of proper like mouthwash that contains like dexamethasone and all of these antimicrobial agents, most of my patients, at least, they tolerate this kind of treatment. And I had really good progression-free interval with most of the patients who have been treated with mTOR inhibitors.
I would add just one thing that we did, the early involvement of palliative care in the management of all patients, of course, and especially in patients with breast cancer, not to wait for the patient to need palliative care, as our classical thinking helped us a lot in managing the mucositis. These guys, they are doing a marvelous job in looking after this. Talib, what about Princess Margaret? You came about 2 years from there. So what was it, the situation there, considering the same in Toronto?
The same thing that they are not allowed to use CDK4. They are not allowed to use mTOR, the Everolimus, if you are using as a second line. They allow only CDK4/6 inhibitors, and if there's a progression, you can go ahead for second line. The experience with mTOR inhibitors, still, my experience, with the humble experience, I would say it is manageable, the toxicity, and I didn't face a lot problem with it. Dose reduction is significant to a certain amount of my patient, but it's a good medication.
Okay.
Prevent chemotherapy or to delay the chemotherapy as much as we can.
Okay. Another question of the same content about the first one, which you are using everything up your sleeve. The same thing. If you are using CDK4/6 inhibitors, for example, in the adjuvant setting, what do we do with the patient if he progressed later and he developed metastasis? And the same thing, or the neoadjuvant setting. And the same thing, if you have metastatic disease, I do believe that it was covered by by Professor Levet. So Professor Levet, it's the same. I remember somebody I know, I was trained in the UK, so there is someone who's very famous. He used to say something, and by laughing, by smiling, I do believe that you knew him now. He said, don't use everything up front. Keep something up your sleeve when the patient actually requires, and then you can treat him, which is really nonsense at that time. And by the way, that guy, if you answered him in the fellowship exam, apart from this, he will fail you. And he failed someone for that. I don't know if you know, maybe you know him. But thank God, all these fashion people, they went away. So what do you think? If the patient had a CDK4/6 inhibitor, say, in the adjuvant, in neoadjuvant setting and in adjuvant setting, then what will you do? The other question is that, will you do PI3K testing upfront in all patients, or then you keep it if the patient recurred or the patient had progression? So please.
So, if that was directed to me, I think what I'd say is I think the interval between stopping the CDK4/6 inhibitor and the relapse is going to be important. I think if someone relapses while on a CDK4/6 inhibitor, then you've got to look to try something else. But clearly we have no data yet, but I suspect it will be very tempting to try and restart a CDK4/6 inhibitor, possibly with fulvestrant rather than an AI, in those patients who relapse having had prior exposure. With regards to the second part of the question, I really do suspect that the future may lie in liquid biopsies and being able to see what's happening in the metastatic setting. And I suspect that may give a better indication than looking at the primary tumor for whether someone's going to get response second line to alpelisib or similar agents.
Before I turn to the guys for the same question, I'd like to ask you something about the regulatory process in the UK. Do you think NICE will approve neoadjuvant abemaciclib, for example?
Adjuvant abemaciclib, I think it probably will. Yes. I'm optimistic. I very much. What they may do is what they quite often do is approve these things for a limited time. As they gather in more data through the Cancer Drugs Fund, and then they do look at that data, and if they see that it hasn't proven to be as good as hoped for, then they cut the funding at that point.
Dr. Sharif, now you are the second to answer the question.
Thank you very much. Thank you very much. So I think, Dr. Assam, with the introduction of new treatment and even moving more effective treatment to a upfront setting, I think we always will have new questions and new challenges. But again, the key answer is, of course, in the interval. And another answer may come when we have data from treatment with CDK post-progression or re-challenge with CDK. We have different trials in metastatic patients who have been previously treated with CDK4/6 inhibitors and hormonal therapy, and then they will shift the hormonal backbone and will continue on CDK4/6 inhibitor. And we have trials as well with reintroduction or re-challenge with CDK4/6 inhibitor. So I guess these trials as well will add some insights about the value of reintroduction of CDK4/6 inhibitor on patients who have been previously treated. And I guess with when it is approved, CDK4/6 inhibitors approved in early breast cancer, we'll have some experience. We'll have data, population-based data, series of patients that will guide us what to do with those patients. But again, the simple answer is the interval between end of treatment and time of relapse.
Well, let's switch gear to bone metastasis and direct the question to Professor Ghazali. It's about the role of, thank you, Sharif, for the very nice presentation and review, by the way.
Thank you.
The role of denosumab and the period of its use in metastatic setting.
Yes, I think we all have this very good experience with these drugs. And it is almost used now in, as Dr. Sharif clearly show in the talk about the guidelines of using this denosumab in supporting patients, either to go for the monthly base or to start in first year monthly, and then to increase the distance or the duration every 12 weeks. So we have the same in the practice now. The most important side effect, you all know that the necrosis of the jaw, which is likely like a hell when it happened. So it will be something very serious. So usually, if we can go for increasing the distance between the denosumab every 12 weeks, I usually going to this schedule to try to decrease the possibility of this risky side effect.
Okay, now let's round it up by some direct questions, yes or no, agree, disagree, or I will just use it or do it in special occasions. So, for example, the first one is that, do you think that TDM1 is taking over from Herceptin as a growing role in the treatment, or substituting actually Herceptin and the other options? Yes, no, selected population. So we'll start with Sharif.
What's in the adjuvant? Yes. In the residual disease, yes.
Actually, they didn't actually clear the question. So
in
we'll just
subpopulation. So
yeah, so
I think in subpopulation.
Residual disease, yes.
Yeah, exactly. Talib, I'm going with the order of the screen that I can see.
Yeah, yes, and even in metastatic as second line, yes, even.
Yeah. Ahmed?
Yeah, as everybody, adjuvant in residual cancer, metastatic in second line and beyond.
Professor Levitt?
Agree. In those settings, yes, but outside of that, replacing Herceptin, no.
Okay, the second question, I will start from the end, from Professor Levitt, actually, because she's on my screen now. Do you agree with you to use CDK4/6 inhibitors as adjuvant therapy in high-risk hormone-positive patients? Yes, no? We should take toxicity, especially financial, into consideration. These are the three categories.
Yes.
Yes. So do you think that we should take into account really the financial toxicity? I know in Saudi Arabia, it might not be a big issue because the government, for most of the patients, they are covering it. But do you think that using it as early, especially in the adjuvant setting, which may represent a challenge in terms of financial toxicity?
I guess the answer for that is that the data is too early. And I think what will really matter is the overall survival advantage. And I think if all these drugs are doing is just delaying relapse, but not improving overall survival, then no, I think that would be very uninteresting. But if they actually save women's lives, then I think the finances become much more acceptable.
Ahmed?
Yes, I totally agree. In high-risk hormone receptor positive, I would use abemaciclib, yes.
Talib?
Yes, I agree. And I have a question for Dr. Levitt.
Yeah. Hold it until we finish this, please. Just 1 second. Okay. Dr. Ghazali?
Agree.
Sharif?
I will wait for longer follow-up.
Thank you. And the second question, Monarch E, abemaciclib study is positive study. Do we have concern about diarrhea? So agree, disagree. I have concern about regarding diarrhea, but it can be manageable. We'll start from also Sharif.
Manageable. Yeah, we have concern, but it's manageable. We know how to manage it.
Hisham?
Yes, we have some concerns, but manageable in most of cases.
Talib?
Same thing.
Ahmed?
Manageable toxicity, yes.
Okay. Professor Levitt?
Manageable toxicity.
Okay. Thank you. Now the last, or not the last, the one before the last, denosumab is the standard of care in metastatic breast cancer with bone metastasis. Do you agree with that or disagree? Professor?
Yes.
Okay.
Yes.
Okay, I think everybody agrees.
Yes.
Now, Tali, please go ahead with your...
I want to ask Dr. Levitt about what's the main reason that for BALAS trial came negative compared to Monarchy?
I think there are a number of issues. I think they didn't have the same high-risk population. 40% of patients came off palbociclib early due to adverse events, and you're not going to get any benefit if you're not actually taking it. And I think probably it was started too late. So I think you need to start earlier if you're going to prevent early relapse.
So what I know that from BALAS trial, they include even the high-risk patient, which is stage 2B and above.
They did, but only 60% of patients on PALAS had either 4 nodes positive, or only 60% of patients on PALAS had the same kind of high-level disease that 100% of patients had in Monarch E. So there were more patients who quite probably aren't going to get the benefit.
So in monarchy, they tolerate the medication well compared to Pallas. So this is the main reason. If we say why it is negative,
I think it was the trial design, probably, rather than a difference between inherently between abemaciclib and palbociclib. But I guess we won't know that. Although if Natalie is also a positive trial, then that would imply that it's more to do with exactly what population and when you give these drugs, rather than which of the drugs you give.
okay. Thank you, Dr. Lavi.
May I ask a question? Final question, if you allow me. Dr. Lev, do you think that it's not only the design or the type of patient included? Maybe we have some explanation coming from the medication itself. If you look to the Monarch 2, more patients with primary resistance, better outcome with the abemaciclib compared to less resistant patient. And the reverse in the subgroup analysis of palbociclib trials. More sensitive patients have better outcome compared to more resistant patients. So do you think that palbociclib may not be the right treatment for resistant population or patients having high risk patients? This may be an explanation or hypothetical explanation at least.
Certainly, absolutely, definitely a hypothetical explanation. I mean, I think it's really difficult to say. I think in those patients, maybe a SERD might be a better backbone than an aromatase inhibitor, which hasn't been looked at again for a long time in the adjuvant setting, and certainly in the metastatic setting, abemaciclib is often the CDK4/6 inhibitor of choice in someone who's got significant visceral disease. So it may be that there is a genuine difference between the drugs.
Okay, the last question, I'm not going to actually say it because it's political and we will go off the air. Okay, from our colleague Dr. Ali Bajoda about the availability of medications. Anyhow, thank you very much to all of you. We have enjoyed every and each presentation and the discussion. Thank you, Dr. Samani. So I started with you now. Okay?
Thank you very much.
Thank you, Dr. Samani, for the nice presentation. Thank you, Ahmed, for your nice presentation as well. And of course, thank you, Professor Levitt, for the excellent presentation. And thank you for the chairpersons, Dr. Talib Bouhlega and Professor Hisham Al-Ghazali. And we hope to see all of you in person, which I'm not very optimistic about this until the end of 2021. I do believe that Corona will stay until 2022. Okay, God forbid.
Thank you very much.
Thank you very much. And now we move to the chairman and the director of the oncology department at Prince Sultan Medical Military City, Dr. Abdulaziz Al-Hamad.
Thank you very much, Dr. Aslan. Thank you, Dr. Hisham. Thank you, Dr. Talib. I'd like also to thank all the speakers. There is small changes in the schedule. We're going to start with the second satellite symposium, Pfizer. Then we're going to end with the satellite symposium by Amgen. It's my pleasure to present my friend and my colleague, and my senior colleague, Dr. Isam Murshid, who is a senior medical oncology consultant, who did his training in UK. I will not say when, but a long time ago. He will give us talk about palbociclib in the real world. This is sponsored by Pfizer. I'm very sure that will be richful and very interesting talk by Dr. Asaf. Thank you very much.
Thank you very much, Dr. Hamad. By the way, I graduated medical school when I was 9 years of age, so I'm very young. I was a brilliant student. Anyhow, thank you very much for the nice introduction. As Dr. Hamad said, we have to disclose that this is a satellite symposium with an honorarium given by Pfizer for this presentation, which will represent the palbociclib combination in advanced and metastatic breast cancer, the real world evidence. Okay. These are my disclosures, and I said an honorarium have been received by Pfizer for this, from Pfizer for this. The topics will go into about 5 topics that we'll talk about. The first one is the palbociclib real-world evidence and the clinical effectiveness. To start with, why we are very much interested now, the interest actually is growing in the real-world data, and how we do that. Real-world data simply means that you go to the practice after the approval of the drug within the label description of the drug, and you start to collect data from mainly from electronic records, and you may use actually the electronic records, you may use even applications used by patients nowadays, and medical record, and even sometimes reviewing the bills from the insurance companies. All this will be audited, data will be extracted, and you will raise some questions. You may use certain modules of technology, of machine learning, and processing. These data to be included in the real-world data should be of high quality, should be complete, should be transparent, generalizable, and timely and scalable, which makes actually verifying this data is a difficult job. What you do with it, you can use it for regulatory purposes in approving certain drugs, in expanding the label indications of some drug, in raising up questions for research, and as we said in the discussion in the previous session, of hypothesis generating sometimes, and also to guide clinicians, because most of the clinical trials and the treatment are being delivered by either academic centers or specialized centers. So we are leaving out those who are the so-called in America, the community oncologists, and for us, people in rural areas. So there is definitely a difference between the real-world data and the clinical trial. The clinical trial will look directly into causation or causality, okay? But the real-world data is does only evaluate association, okay? So it does not determine causality. Patients in randomized setting are randomized. Patients in the real-world data are not randomized. And in the randomized clinical trial, you have a defined protocol with defined inclusion criteria, endpoints, and minimal variation in care. So you have to stick to the protocol, where this is not being applicable in the real-world data, and it's more dependent on the clinical judgment and variability. So, and the real-world data is highly monitored and controlled environment, while in the real-world data only you have routine clinical practice and with a broad patient population and practices. And we have to mention that real-world data is an observational study rather than being prospective. Either it's an observational or retrospective analysis. And by all means, we don't use it actually to compare with the standard randomized clinical trial, but it may complement the results coming out from the randomized clinical trial. Now we'll talk about the ERIS, which is the IBRANCE real-world insight, and this is a retrospective chart review. And the objective of this is to study the demographic, clinical characteristic, treatment pattern, clinical outcome of US patients who received palbociclib within the label indications by the FDA. The study design, as I said, it's a retrospective medical record review of more than 650 patients by 65 physicians. Here, you choose the patient, okay, or you have eligibility criteria for the patients and for the participating physicians. This may raise selection bias, of course. So physicians should be oncologists, hematologists, or gynecologists, those who are treating 5 and more hormone positive, HER2 negative, locally advanced or metastatic breast cancer who meets the eligibility criteria to be included. And patients should be 18 years and older, confirmed hormone positive, HER2 negative disease, and no prior or current enrollment in an interventional clinical trial. So these patients should not receive these medications or similar in a clinical trial, and they should receive actually the palbociclib within the label indication. And what the physician will complete the electronic case report forms between July and July 2017 for up to 16 sequential patients treated after the index date, and the patient should actually use the medication for 3 months or more, either palbociclib plus AIs or palbociclib plus fulvestrant, with a sufficient follow-up period required. The patient demographic or characteristic, they are almost very well balanced. And as you can see here, this reflects actually the ethnicity of the American people, where Caucasian and whites are the majority. And also at the same time, it may reflect the access to care to certain minorities. More than 50% of these patients, they recurred after adjuvant therapy, and less than 50% of these patients were de novo metastatic disease. Mostly were metastatic disease in recruitment, about 80%, and less and 20% were locally advanced disease, with most of the patients had very good performance status. More than about 80% of patients, they were either grade 0 or 1. Most of these patients, or more than 50% of these patients, they have non-visceral disease, and around 45–46% of these patients, they're either bone only or visceral disease only. And these patients, they have received treatment lines according to the practice that we are following. Of course, the first line or the first treatment to be received is letrozole. If the patient did not receive that before, if the patient received letrozole, then we would use fulvestrant or other fulvestrant, and in the first line we use the AIs of different types. Dose modification or dose reduction, most of the patient, around 3/4 of the patient, they have received the full dose of 125. Only 14 and 19% of patients, according to the endocrine partner, they had dose modification to 100 milligrams, or very less likely those who received 9 milligrams, and most patients actually who discontinue or who had reduced dose, it was because of toxicity. In my practice, I've never used actually the 75 milligrams. As you can see, the progression, the endpoints or the definition of endpoints in the real world data is different than in those of the clinical trials or randomized clinical trials. Here, they have defined the progression-free rates. As you can see, whether the patient received AIs or received fulvestrant, there was, of course, consistent benefit for the patient, which decreases by time, which is natural. Those patients, by time, they lose control. And as you can see here, the demographic of the patient, almost half of the patient were above 65 and half of the patient below 65. Performance status, most of the patient had very good performance status, and very less patient, they had poor performance status. Metastatic disease, visceral and visceral almost equal, around 50% of both in both groups. So in IRIS, as you can see, there is an advantage for adding palbociclib AIs or palbociclib fulvestrant, and the patient who will benefit the most are those with very good performance status or good performance status. Patient with non-visceral metastases, they do better relatively than others. The same thing about the, I think I'm repeating myself. Okay. So in conclusion, the IRIS trial, the study specification and limitations did not include a control arm because it's not non-randomized. Clinical event could be adjustable based on clinical criteria used by the physician, is not being used by standard criteria, for example, the RECIST criteria. Adverse reaction were not mentioned at all in the study. It relied on the availability of detailed, it relied actually on the credibility and the availability of detailed medical information in the medical record, and it dependent on the correct completion of the CRF by the doctor himself. Okay, so integrity is very important for this. Data were only allocated by physicians who were willing to participate. This, as I said, or or doctors who were selected. So this might introduce a potential selection bias. The validation of the data collection is not there because this is not randomized clinical setting, and the follow-up period was not uniform between for patients and for doctors actually. So this represents very much challenge in interpreting these data. And these data are sample specific and cannot be generalized because here we're not randomly assigning patients or just using the normal randomization process. So it cannot be generalized to other population or subgroups. All right, so physician-reported clinical outcome in patient who received ribociclib in combination with the fulvestrant demonstrated a landmark progression-free survival consistent with the randomized clinical data. And I would stress again, we should not compare, but it's a complementary result to whatever we have seen in the randomized clinical setting. Ongoing studies are required to deliver results or mature data of longer follow-up, and this being carried out. The frequency of palbociclib dose reduction was not much actually, but it was less than what we have seen with the Paloma trial. And this reflects the bias in selecting patients who might be much more fit to receive treatment than in the clinical trial, although this is an open question. Now we move to the Flatiron electronic health record database study. Flatiron is a company actually that gathering data or the electronic health record data and allows for sharing it with other health providers. And party of interest, and part of those are drug companies or pharmaceutical companies. It's the overall survival of first-line palbociclib plus letrozole versus letrozole alone for HER2 positive, for hormone positive, HER2 negative metastatic breast cancer patient. And this was published in San Antonio last year, the last physical San Antonio we attended so far. Okay. The Flatiron, the objective, it's a retrospective analysis of the electronic health record systems conducted using de-identified patient data from the Flatiron Health Analytic Database to determine whether the real-world data could demonstrate improved progression-free survival and or overall survival for palbociclib plus letrozole versus letrozole alone in the first-line setting. And these are the exclusion and inclusion criteria. The inclusion criteria, of course, hormone positive HER2 negative, diagnosis of metastatic breast cancer at any point of history, date of first prescription, because they have to identify it was between February 2015 and February 2019. Potential follow-up was at least of 3 months for patients who received the treatment. The cutoff data was in May 2019. Exclusion criteria, of course, the country if the patient had prior CDK4/6 inhibitors, other hormonal therapies. So this should be the first line treatment. And if the treatment with CDK inhibitor as part of a clinical trial. Don't worry about this. This is the definition or the explanation of the trial when they calculated the progression-free survival if patient progresses or dies, and if the patient actually did not have an event at the end of the cutoff data, she is censored actually. So they will be censored, and this may affect the outcome, by the way. And the same for the overall survival. Either the patient who dies at the cutoff data, or if not dead, then they will be censored. The statistical analysis used and the BSM, which is the propensity score matching system used to balance the baseline characteristics of patients in the observational trials. Again, As you can see that the patient demographic or patient characteristic were very well balanced. Most patients were between the age of 50 and 75. And again, most of these patients were whites compared to other minorities. And interestingly, that most of these patients were treated in a community oncology, i.e. in the office practice, that it is not a specialized care and it is not in big academic centers. And it included actually, this is at diagnosis and then when they recur, and with most patients had very good performance status. Most of these patients actually did not have, or less than 50% of patients had visceral metastasis. Bone disease was only reported in 35% of these patients, and very low incidence of brain metastasis. Almost the brain metastases were excluded from the analysis, and it stratified patient according also to the numbers of metastatic sites, whether de novo or at recurrence. And as you can see here, as we saw from the randomized clinical trials, there was a significant improvement in progression-free survival for patients who had combination of palbociclib letrozole versus single-agent letrozole alone. And this support the data that we are saying, this complement the data that CDK4/6 inhibitors combination should be the standard first-line treatment in those patients. The same for the overall survival. There was a significant difference, and the difference was there among all subgroups except for race. Actually, the Black they did, or the African American they did worse. Sorry. The Flatiron database, or the second-line therapy after failure on CDK4/6 inhibitors. Of course, in the real life, some people we still sometimes use another CDK4/6 after the progression on the other one, though the evidence is very weak for doing so. Chemotherapy was very much less used in these patients, and in the second endocrine therapy also was not that popular. So the real-world data in this setting actually complement, as I said, the effectiveness of the combination versus the single-agent letrozole in terms of progression-free survival and overall survival. And the data actually complement the superiority of the efficacy observed with CDK4/6 inhibitors in combination, again, as a single-agent AI. And also, there are certain limitations, of course. What we are doing here is that we are reviewing records that being written by someone. It might be complete, it may not be complete, it may miss some information. So this is a major limitation. Also, the entry of data, when these data are entered, we know that some errors may happen actually. And we can see it in clinic that either spelling mistakes or different patient names and etc., or missing information. Disease progression, as I said, was based on each physician preference rather than standard RECIST definition from different hospitals. Of course, sometimes your radiologist will not tell you the percentage or how much response that the patient had, and then he will only mention that the patient progressed or the patient is responding. Sometimes even stable disease will not be mentioned in certain reports. And at the same time, because it's not randomized, then you may fall into the selection bias, and comorbidities were not actually very much addressed in these settings. Sometimes the oncologist will just write this patient is known breast cancer who came for the second cycle or whatever, without even sometimes mentioning the details of other problems, because it's the problem of other people to mention and to follow. Okay. And also the analysis of this data represent a challenge by itself. This is the poster which was presented in the San Antonio, I do believe, of 2019, the last one we attended physically. The real world data, tumor response of palbociclib plus letrozole versus letrozole, which was published this year as a poster in the ESMO, the same actually. Exclusion and inclusion criteria, and they were looking into the response rate or assessing the response rate in those patients who started treatment for a certain given time, either with radiology, clinical, or lab. The same thing with the group distribution. It's almost identical to the last one without any much difference. And as you can see here, that the patient who received palbociclib, an adjusted cohort or adjusted cohort after the BSM, actually they have benefited much from, they had more overall response, more partial responses, and more stable disease, which actually support the same thing that we had from the, or complement, let's say, now rather than support from the randomized clinical trial. This assessing response, this also showed you the assessment of response and the better overall response rate and other response criteria. Okay, in summary, patient who had the combination of palbociclib letrozole versus letrozole alone, they have better overall response rate compared to patient who had the AI alone or the letrozole alone. The data complement, as I said, the benefit observed with the CDK4/6 inhibitors, and limitations actually the same, almost the same limitation. You don't have very much accurate tumor assessment or response assessment systems. It's not unified between the centers. We are dealing again with a record that it may involve human error in dealing with it, either during entry of data or during actually writing these data or interpreting these data. There is no systematic way of assessing the radiological response, and the findings from the retrospective analysis of the Flatiron database may not be generalized, as I said, because we are targeting a non-random population and no causality, of course. Again, almost it's like a repetition of the same thing, consistent and looking into the objective response rate, looking into the progression-free survival of those patients, and it was it did complement the results that we have from we have seen with the randomized clinical setting. So it's almost the same thing. The effect is there. The limitations are the same, and I would just summarize these limitations into a human error in taking data, entering data, and repeating data, the standardization of response assessment, okay, whether clinical, radiological, or even sometimes, because in clinical settings, sometimes you may take biopsy, but you cannot do this in real life. The male breast cancer, the same actually. I will just go through this quickly. They have looked into specific data for male breast cancer because we are blessed in the real world that we may treat, although in the clinical trial not much male patients were included, if any. But in the real life, you apply whatever you know about women in breast cancer and you apply it for the poor men. And the same thing, there was consistent benefit for the use of the combined approach versus the single approach. Now, the Madman Trial, I don't know, they like to call it with the, someone told me that sometime we will run out of the trial names. The Madman Trial, which is of almost a similar design, looking into a patient who had initiated the therapy, and they related it to the number of the clinic visits. The outcome was almost the same, and this was published in, this was published in San Antonio, I do believe, in ASCO virtual meeting this year, and it shows very consistent result with the benefit of palbociclib plus hormonal therapy. Okay. In terms of, and also the quality of life was assessed in these patients, and it was in favor of using the CDK4/6 inhibitors with no added toxicity than what we have seen through the clinical trials, and these toxicities are manageable, especially the low WBCs or neutrophils. Okay, so I do believe that we are done with this. So just before I leave you, I would say that real-world data is a growing topic nowadays. It can help you in It can help you in designing your future trial because it may give you, it is hypothesis generating. So it got a positive effect of research, complementing the result. And also it may help regulatory bodies to expand certain label indications of some medications. It may allow access of the medication to groups which were excluded during the clinical trial or not recruited during the clinical trials, like, for example, patient with comorbidities, patient with poor performance status, and male patient in breast cancer. They have more fair chance of accessing the medications and to assess the response among these. It may help actually in developing the artificial intelligence models in interpreting data and replacing us as doctors in the future with computers and machines. Thank you very much.
Thank you very much, Dr. Assam, for this interesting speech and very comprehensive talk. We'd like to take two quick questions. The first one, I think, what do you mean by non-visceral metastasis? I think you mean bone metastasis, right?
Non-visceral metastasis, either bone or soft tissue.
Okay, that doesn't include the brain.
No, of course it does not.
Okay. The other question, actually this comment, it is good to validate our experience about the use of palbociclib retrospectively. The dose reduction was very common in Saudi Arabia population, and the efficacy of these treated with 75 milligram is not affected by the dose reduction according to our observation. Do you agree with this?
Yeah, actually, I would. It's in our experience, I believe, as you know, we go to the numbers that what strength of medication we have bought, and when we reviewed that, we have found that we have never requested the 75 milligrams, as you remember. So most of our patients, about more than 80% of patients, they were okay on 125. Less than 20% of patients, about 15 to 20% of patients, they had dose reduction of 100%. So in my view, it was very much well tolerated. Of course, we had some events of neutropenia that it did not much affect our decision in delaying treatment. We have used alternative either before using dose reduction. Sometimes you use alternative scheduling, but it wasn't that much. And 75 milligrams, as you know from an initial point, we have never requested that.
Okay, I think that's it. Thank you very much again.
Thank you.
And really enjoyed your talk. And now it's my pleasure to introduce my colleague, Dr. Mervet Mahrous, who is gonna be moderator for the next satellite symposium by Didi Company. Dr. Mervet, تفضل.
Thank you very much, Dr. Abdulaziz, for introducing me, and thank you very much for holding this meeting and all the organizing committee. It's my pleasure to chair this session, Amgen meeting, satellite symposium, and we'll speak about a very valuable topic, which is biosimilar in breast cancer. We know that the prices of the medications is going up, and we have a lot of target therapy. But now I think it's time to think about the biosimilar. So it's my real pleasure to introduce Dr. Giuseppe Gregiano. Dr. Giuseppe Gregiano, he is head division of early drug development, European Institute of Oncology, Milan Associate Professor of Medical Oncology at University of Milano, member of the nominating committee of European Society of Medical Oncology, and he was a fellow of the European Academy of Cancer Science, member of Superior Decenti, and of course he is very well-known name as a member in the breast cancer society, and also in the breast cancer field with plenty of publications, and he is very well-known. Thank you very much, Dr. Giuseppe, for joining us. It's our pleasure. And his talk will be the role of trastuzumab and its biosimilar in breast cancer. Dr. Giuseppe, please.
So thank you very much for your kind introduction. In the next 25 minutes, I will try to discuss about the role of trastuzumab and its biosimilars in breast cancer. So let's start discussing about TER2 and trastuzumab in breast cancer. We know very well that since the monotherapy trial that was completed in 1999 to 2017, we had many new data in which trastuzumab use impacted alone or in combination with pertuzumab in overall survival of patients first with metastatic breast cancer and then with yearly breast cancer. So, of course, it's quite important to understand that any drug will be, of course, expired in terms of patents. So new agents are coming, and I would like to support the use of biosimilar because from the clinical data that we have, of course, we have several biosimilars that actually have been developed in the context of breast cancer. Some of them provided data in the neoadjuvant setting, I mean ABP 980, SB3, CTP6, Mylan 14010, and Pfizer 052814. It's important to remember that according to the regulatory agencies, we don't need to have a trial in the neoadjuvant setting, but it's enough to have a trial in the metastatic setting to approve a biosimilar, because biosimilars are approved based on non-inferiority trial. So you don't need a trial in the neoadjuvant setting and in the adjuvant one. So the idea of several companies to complete a trial in the neoadjuvant setting was done just to assure clinicians that the use of biosimilar will not affect the rate of pathological complete response in the neoadjuvant setting, but not because there was a specific need based on regulatory agencies' requirement. So this is an example of equivalence phase 3 study design in the neoadjuvant setting. ABP 980 versus trastuzumab in HER2 positive yearly breast cancer. So patients received the first diagnosis of HER2 positive breast cancer, histologically confirmed with lesion of 2 and more centimeters. Then they received the EC for 4 cycle, exactly like a standard of care. And then patients have been randomized to ABP 980 for 4 cycles plus paclitaxel, or trastuzumab reference drug every 3 weeks plus paclitaxel. Then patients received surgery, and there was, of course, a possibility of switch of ABP 980 up to 1 year, or, and this is very interesting, the preference of the patients to receive also ABP 980 for 1 year or trastuzumab for 1 year. So here we have really the opportunity to explore if there are any differences between the biosimilar and the originator. So the first observation is that in the neoadjuvant setting, look at the data. The rate of PCR with the biosimilar was 48% versus 41% in the originator. So the first observation is that we don't have absolutely an inferiority of the biosimilar respect to the originator in achieving a pathological complete response. And I believe this is a very important information. When we perform a sensitivity analysis with a central lab evaluation of pathology, we still confirm that ABP 980 is superior to the originator in achieving a pathological complete response, even if this is not statistically significant because this is a non-inferiority trial. What's about anti-tumor activity in ABP 980? Any biosimilar can be approved based on strong analytical and preclinical data. Because in order to bring a trial in the metastatic setting and in the clinic, the regulatory agencies are just asking to you a non-inferiority trial. So that's why for biosimilar, we have very strong preclinical and analytical data. So those are data demonstrating clearly that ABP 3 milligram per kilo, 10 milligram per kilo are more effective than trastuzumab originator. So it's quite important to remember that this antibody is really had the opportunity to target HER2 and to be very efficient. The pharmacokinetic data are not different in different populations. So if you look at the data in metastatic breast cancer, in early breast cancer, or advanced gastric cancer, there is absolutely no difference in AUC in terms of pharmacokinetic. it's quite important to remember that the SP3 phase 3 study finally is a randomized prospective study evaluating the activity of SP3 primarily in terms of pathological complete response, and then in terms of overall response rate, event-free survival, overall survival, safety, PK, and immunogenicity. And the most important thing is that in most of the cases, the efficacy results can really favor SP3. If you look at drift monitored in reference trastuzumab, there is absolutely no difference for trastuzumab biosimilar versus the originator. And the number of patients which events was 17 in SP3 and 31 in the trastuzumab arm. So also the 3 years event-free survival favors SP3 respect to the originator. And this is the follow-up for event-free survival. It's impressive to remember and to notice them. So this is really a very good agent. Finally, we have to remember also the concept of extrapolation. What is extrapolation? Once you approve a biosimilar in a disease setting specifically that can be the metastatic one, and in a sensitive population that in this case is their HER2 positive disease, you can extrapolate the data also in the adjuvant setting. This is a biosimilar and is exactly the same from the preclinical point of view and from the analytical point of view to the originator. So we really don't have any differences across the two drugs. And we have really an heterogeneous population because we have data from the early breast cancer setting. So what is important to extrapolate from the metastatic to the adjuvant setting is that the biosimilar development usually have a lot of evidences based on preclinical and analytical data. So that's why in the context of the clinical study, you just need a non-inferiority trial. And the scientific justification is based, one, on the mechanism of action. In preclinical data, you clearly demonstrate an high affinity for the target and, of course, an ADCC activity. The PK data are exactly the same. Immunogenicity is exactly the same. And in terms of toxicity, there is no additional toxicity. So another example is the biosimilar bevacizumab, in which selecting a sensitive population for a phase 3 comparative clinical trial, you may have exactly the same activity in several diseases. Another important observation from the trial with SP3 is the switching and biosimilar initiation in treatment-naive patients. So the unique characteristic of the study is the single switch. So here the patients received first trastuzumab originator, and then after surgery, they have been randomized to ABP 980 and trastuzumab. So this is a very important study because I believe there is no other study in which this type of comparison has been performed. And knowing that the event-free survival data and the safety is exactly the same is really reassuring. So the biosimilar trastuzumab ABP 980 in terms of comparison to trastuzumab originator, we don't have an increase of infusion reaction that are exactly the same in terms of percentage, 7% for the originator, 8% for the biosimilar. No difference in terms of neutropenia, 8% versus 10%. No difference in terms also of infections or infestations or in terms of hypersensitivity. And here, if we look at the data of switched from adjuvant trastuzumab originator to ABP 980, we don't have absolutely no difference in terms of statistical endpoints. Biosimilar trastuzumab, of course, can also bind to antibody in a very similar way to trastuzumab originator, and the antibody drug antibodies are not different respect to the originator. So if you look to all the guidelines, the ABC, the ESMO guideline, they are all endorsing the use of biosimilar. Why? Because we can save a lot of money. And all the money that we save for the treatment of trastuzumab biosimilar then can be used for other disease. So it's very important to remember that special articles are supporting the use of biosimilar. It's important, of course, the communication to patients regarding the switch. A survey has been conducted for other disease, in this case for the Crohn's and ulcerative colitis disease, and 42.8% of patients felt they should be systematically given information about biosimilar. You know, if we look at the European Commission consensus, it's important to inform the patient that when you use a biosimilar, you have preclinical and analytical data that strongly support the use of the biosimilar. There is absolutely no difference. This is an important message. Those are not cheap drugs. Those are highly technology drugs that have exactly the same activity of the originator. And if you look at the history of the originator, you should know that between the first introduction of trastuzumab in clinical setting in 1999 and now, there are at least 13 different biosimilar of the original biosimilar of the original trastuzumab. So it's just fake news that those are cheap drugs. Of course, patients must be informed that you are going to switch to the biosimilar, and you should inform them that we have a clear evidence of the same activity. So the shared decision-making is an important tool for implementing behaviors change, at least in countries where you still can use the originator, because you should know that in countries where we have a national health system like UK or like Italy, actually we cannot use no more the originator. We are only using the biosimilar because the pharmacists do an automatic switch. So we don't have any opportunity no more to access to the originator. So since 2 years, in my country, in Italy, we are using only biosimilar. Of course, when you discuss with the patient, you need a shared decision-making, but I had no single patients that decided not to receive a biosimilar. So the nocebo effect should be taken into account. So because the questions of the patients may be, why are you changing my treatment? If it is cheaper, doesn't mean that it's not good. What should I do if I think that biosimilar may increase side effects? Is it safe? If it is approved for another condition, can it work also for me? Might I have to change again later? How do you know biosimilar is good as my usual treatment? So you should explain to all the patients that the activity is exactly the same because you have strong preclinical data, you have strong analytical data, you have PK data, and you have a non-inferiority trial, both in the metastatic setting and also in the neoadjuvant setting. And finally, I am quite sure that the patient, if you explain everything, will accept for sure the treatment. So first, biosimilar can also be associated with the nocebo effect because the perception of the patients can be that they can worsen the symptom or they can increase adverse events. But overall, we know very well that this will never happen. So the triggers for this perception of the patients is the negative information, the lack of knowledge about biosimilar, and the lack of coherence in communication. So if you communicate to the patient, you will obtain the best confidence from the patient. And of course, with an empathic attitude, also a very good compliance from the patient. So in summary, trastuzumab changed the biology of HER2-positive breast cancer, improving survival both in the early breast cancer setting and in the metastatic breast cancer setting. All biosimilar have been tested in adequate trial. with the important results in the neoadjuvant setting and also in the metastatic setting. The LILAC trial that I presented to you was the only one to explore the switch design. After surgery, patients had been randomized if they previously received trastuzumab to the same trastuzumab versus the biosimilar. Transparency is the key rule for patient communication. And not only Germany, but also Italy switched to biosimilar exclusively, actually, also in my country. So thank you very much indeed. And I will be very happy to take questions from the audience.
Thank you very much, Dr. Just before excellent presentation. I think, as I pointed out before, the subject regarding biosimilar is truly important, and we can see now in ASCO and the ESMO meeting there is a lot of presentations regarding biosimilar, and we know that even now that North American people, they started to discuss the issue before. We know that European country, they are fast track, and they had it. Even you pointed out about Germany, and it's almost 10 years they are using it. And you mentioned that for Italy, it's about 2 years. Do you have an explanation about the slow uptake in regarding North American comparable to the European community regarding the biosimilar? I think it's the main point, that's their fear from the using the biosimilar comparable to original medication. So how you think about this?
You know, the uptake, of course, in countries where there is a national health system is 100% because you have only this. In country where you have not a national health system, it is based on the percentage you can take using the originator versus the biosimilar. So since the biosimilar is less expensive, maybe some medical practitioners are going to use the most expensive drug. This was also described in the past for other type of treatment. But I am quite sure that also ASCO strongly endorsed the use of biosimilar. And I am sure that in a few years also in the United States, more medical oncologists are going to use the biosimilar respect to the originator. At least because also the companies producing the originator will reduce the cost of trastuzumab, I am quite sure.
I think the main issue regarding using, thinking about or starting to think about biosimilar, it's the cost, but at least we need to make sure about the quality and the benefit. But now we do have many companies, they are trying to product biosimilar. So how can you choose between biosimilar in companies? Because usually we are choosing between one medication to the other based on a clinical trials. So now we have some companies, we have Amgen, we have Pfizer, and we have some companies they are starting. So how we can just take step to choose the best?
Now, you know, we choose according to the price in my country. So the less expensive will be the one who will get the target. We did a national call. We are a country of 60 million people. Many companies participated to the call. And the company who offered the lower price won the call. And now in Italy, we have just one of the biosimilars. So it means that the competition across the companies will rise the most important one for the uptake. So they are all the same. I don't believe there is a difference between a biosimilar produced by one company with respect to another. You know, for some companies, you have very interesting trials. The LILAC trial is an example. So no other company assessed the switch from a trastuzumab originator to the biosimilar. So having this data can be for you an opportunity to use much more this because you know you don't have infusion reaction with respect to other ones. So I like a lot the study design for the Amgen drug.
Thank you again for pointed out the point of the psychological element regarding the patient because we have to tell them. So the point that do we need to tell them as information or we have to consent them?
You know, we have to explain to the patient that we are going to use a biosimilar. So because this should be a shared decision making. In my country, it's much more easy because, you know, you say we don't have no more the originator because our national health system will reimburse only the biosimilar. So in this case, in this scenario, it's more easy for the patient to accept, but in any case, you have to explain that any biosimilar have behind a lot of preclinical and analytical data. And we have also at least 2 non-inferiority trials in the neoadjuvant setting and in the metastatic setting. So extrapolation is possible because we demonstrated that that is a very effective and safe drug.
Perfect. You pointed out the extrapolation, and I think it's the main fear for any oncologist that we get used that approved medication based on a clinical trials. So for extrapolation from early breast cancer to metastatic breast cancer or the reverse, and using also in either early breast cancer neoadjuvant and the metastatic setting, and even more for the gastric. You know that trastuzumab subcutaneous, it was even not approved as extrapolation for the gastric. So how we can just only extrapolate based on this and we use it on the second day?
Because we have a very, first of all, because a biosimilar was developed to have lower price and to have less impact on health costs. And secondly, because we have very strong preclinical and analytical data that demonstrate that the drug is a biosimilar of the originator. So I don't believe you will have less efficacy in terms of the adjuvant setting. So the benefit of survival observed with the originator will be confirmed also by the biosimilar. So it's like you develop a generic. If you have a generic for imatinib mesylate, you will use that one because it's less expensive. You don't need a new trial to demonstrate the efficacy, because all regulatory agencies just require a non-inferiority trial in the metastatic setting. So my message is that you can safely extrapolate because there is no issue in terms of efficacy and safety for the patients.
I agree, totally. We do have a couple of questions for our attendees, and thank you for keeping us with us all this period. So what is the difference between generic and biosimilar?
Yes, a generic drug is a small molecule, so you can develop a generic drug from a tyrosine kinase inhibitor that is a chemical process, and so you can generate the drug in the lab. A biosimilar is a living drug, because in order to produce a biosimilar, you need the cell lines that should develop monoclonal antibody. So the process for the development of a biosimilar is much, much more complex and much, much more expensive. That's why on the biosimilar are just moving companies like Pfizer, Amgen, and so on, because those are very huge companies that know very well how to develop biological agents. So this is the main difference.
There is also an interesting question. Is it safe to use Herceptin biosimilar with pertuzumab and tucatinib?
Yes, and we have now also the data, because during ESMO 2019 and 2020 have been presented data combining a biosimilar to trastuzumab originator, to pertuzumab originator. So you can safely combine a biosimilar with pertuzumab with no safety issue, and we have also the data.
Okay, and I think the last question regarding that is there is any subcutaneous regarding the biosimilar? We know that trastuzumab came now as subcutaneous. So the form is only IV, or it can be subcutaneous as well?
So the answer is yes. A Chinese company is producing a trastuzumab subcutaneous that is a biosimilar. They submitted the data to a journal. I cannot tell many things, of course, because data are confidential, but in any case, yes, there is a company producing a subcutaneous trastuzumab biosimilar. It is a Chinese company, yes.
Wow. Last question, and thank you for your time. How about the toxicity profile, and how about the pharmacovigilance? Because we know that the pharmacovigilance in our country, it's optional, not mandatory like yours. So did you face any toxicity profile different than what we are seeing in trastuzumab?
So this is a very good question because you need with biosimilar to report to the regulatory agencies any side effects. So pharmacovigilance is very important when you have drugs approved based on non-inferiority trial. So in my experience, we never observed any infusion reaction that should be reported to the national regulatory agencies. But my advice is to report them if you will observe, because this is very important, of course, to the company to understand if you have any specific lot of drugs where there is any post-prescriptional modification that may increase the risk of infusion reaction. But in my personal experience, I don't have major infusion reaction in respect to the originator.
Perfect. Thank you very much. This was all the questions, and thank you very much for your presentation and the discussion as well. And thank you for all the people who's attending from different regions. And it's my pleasure to close this session. And thank you again. See you tomorrow, inshallah. Thank you very much.
Thank you so much. Have a nice day. Bye-bye.
Thank you, Dr. Ahmed. Thank you, Dr. Basib. It was very interesting and talk in the end. I'd like to also knew the policy in some developed countries like Germany and Italy. Now they are switching, so that might open a new horizon for us here in Middle East.
Yes.
Yes.
I'd like to thank everybody. I think we spent a good time and grateful talk on GI and breast sessions. Tomorrow, inshallah, we're going to resume starting, I think, with the link at 10 a.m. Circle time, which is about 7 a.m. in Greenwich time. For people asking about the CMEs, I think, as mentioned in registration, it's about at least 70% of the conference. I'd like to thank you, everybody. And inshallah, looking forward to see you, inshallah, tomorrow at 10 a.m. Thank you very much and have a nice evening. Thank you.
Thank you.
Bye-bye.